Welcome, Dr. Tapan.
Monica ma'am, we are live now. We can start now.
Thank you, Shubhankar. Surprise, sir, તમે start કરો ને please.
Okay, good evening, everybody. All the dignitaries from the Foxy. Uh, on behalf of AMOGS Emergency Obstetric Committee, this is the webinar episode number 39 with the societies of North Gujarat, particularly Himmatnagar, Patan, Palanpur, and Mehsana Society. Here we are having two interesting talks and one panel discussion. First of all, I am welcoming all and on behalf of Dr. Sneha ma'am on this AMOGS Emergency Obstetric Committee webinar. First of all, Dr. Sneha ma'am, she is the chairperson of Emergency Obstetric Committee. May I have CV of Sneha ma'am, please?
Yes, sir.
She is the contestant for the Vice President, West Zone, for this 2025 2026 year. And she has a great credentials under her name. She is the great social worker, great academician, and she is working from the grassroots each and every corner of the India. She is the international MS Signature Award winner for phenomenal leadership in 2020. In 2021, she got another award, Asia GCC Award in 2008. She got national award out for her outstanding work in rural obstetric. That was Dr. S.N. Malhotra Individual National Award. In 2022, she got Durusa Distinguished Community Service National Individual Award. She also involved in so many social activities.
Yeah,
She
thank
also
you.
got the award by Maharashtra government, Dr. Anandibai Joshi State Award. And another excellence award she got by Lokmat Healthcare in 2020. She has more than 30 years of experience in this field, more than hundreds of talks and publications. She worked in the Foxy Breast Committee from 2019 to 2021, and she is the founder president of Vidarbh ISOPAP. So, Sunita ma'am, the stage is yours.
Yeah, thank you, Sarfraz. In fact, thank you. Can we stop sharing, Shubhankar? Yeah. So, a very good evening to one and all. My respects and regards to all the seniors here. At the outset, myself, Dr. Sneha Buyar, I'm the chairperson of this AMOGS Emergency Obstetrics Committee. I would like to welcome all of you. I especially welcome our AMOGS President, Dr. Kiran Kurtakoti, who is also the chief guest for today's program, and Dr. Alpesh Gandhi, who all of you know, he's the past president of Foxy and the current president of Justices India chapter. I'm sure looking at the topics you must have got how apt we have chosen even the chief guest. Who else can be the most appropriate person to be to preside this program? So, hearty welcome to you, Dr. Alpesh, sir. We have Dr. M.C. Patel, sir, as well. And we welcome you, respected Dr. M.C. Patel, sir. I welcome all the presidents and secretaries of Patan, Palanpur, Himmatnagar, and Mehsana societies. I welcome all the faculties, especially Dr. P.K. Saxena, who will be speaking on screening of hyperglycemia in pregnancy. Yes, and of course, a very revered speaker again, Dr. Sushila Rani from Bangalore, who will be talking specially about the pharmacotherapy or the medical management of the hyperglycemia in pregnancy. And of course, we are going to have a panel discussion, which will be a very practical case-based discussion on hypertensive disorder of pregnancy, which I'll be moderating. And we have esteemed panelists from all over the North Gujarat societies, as we have heard. So I welcome all of you, and it will be our pleasure to listen to you, Dr. Alpesh Gandhi, sir, about your experience in this field and what is your guidance for all of us. So over to you, sir, for your precious words.
So before that, shall we go for lamplight or we should start?
Yes, Sarfraz, actually, please go ahead.
Shubhankar?
Yes, sir.
Shubhankar?
I will
Ah,
start screen sharing.
ah,
Yes.
yeah. Lamplight.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः।
Yes. Can we have Dr. Alpesh sir, CV Shubhankar? So, with the
Yes.
blessings of God Almighty, and of course, we are going to have the blessings of our respected seniors. We are here to welcome Dr. Alpesh Gandhi, sir. And of course, all of you already know that sir is the past president of FOXY and the current president of Justice India chapter. But apart from all this, he is a very gentle, humble human being and guiding force for all of us. He has, to his credits, operational guidelines for obstetric SDU and ICU. Of course, all of you must be aware that it is included in the Government of India guidelines, and FOXY guidelines on pregnancy, the COVID-19, perinatology guidelines on COVID-19 with NNF in IFE. He is one of the advisor for preparing National Register on Pregnancy with COVID-19 along with ICMR. As all of you were listening to Dr. MC Patel sir, that even the uniform consent form was, it was prepared in his tenure. So with this, we welcome you, sir, and we are eager to listen to your precious words. Over to you, sir.
Thank you, Dr. Sneha, for the kind introduction. Dear friend, Dr. Kiran, President AMOGS, and today's chief guest of honor, Dr. MC Patel, past Vice President FOXY. Dear friend, Dr. Archana, Sarfaraz, and Monica, today's convener and coordinators, President and Secretary of Himmatnagar, Mehsana, Patan, Palanpur societies, and all the esteemed faculties. A very good evening to all of you. I am thankful to Dr. Kiran Purkurti, President AMOGS, and Dr. Sneha Buyar, Chairperson, Emergency Obstetric Committee, AMOGS, for giving me this opportunity. I would first like to congratulate Dr. Sneha for this episode number 39. I know it is very difficult to continue this many number of episodes. You are doing really a very good work, very good academic work, social work. I know you since long, and Sneha was committee chairperson with me, and I have seen her working very sincerely and with passion for FOXY. Today's topic is very, very important. It is in one of the study of ICMR, it was found that the incidence of high-risk pregnancy in India is 49%. It means out of every 2 pregnant women, 1 is having high-risk pregnancy. And in another study, it was found nearly 35%. So in that study, it means out of 3 pregnant women, 1 pregnant woman is having high-risk pregnancy. And that is why this webinar is very, very important. We regularly need to update ourselves. The 2 topics selected for today's webinar are really very important because hyperglycemia is one condition where India is the capital of the world. India is the capital of GDM in the world, and the incidence is between 5 to 10% in different states, and it is day by day increasing. Again, about the hypertension disorder in pregnancy, the incidence is around between 10 to 13% in different studies in different states. And if you look at the admission of HDU, obstetric HDU, then hypertension disorder in pregnancy is number one indication for the admission in HDU. Both the conditions are directly and indirectly responsible for many complications. It can affect all the systems, and even it can affect both mother as well as fetus, neonate. So it is very, very important to discuss this, both the conditions. Previously, there were a lot of, we can say, confusion, because there were different definitions, different values, different guidelines. But now we can say in last few years, it is more or less now everything is streamlined from definition to classification to screening and management. So previously there was a lot of confusion, but now it is not there. We need to learn this not only as per this recent updates, but also considering Indian context also. And being president of Justosis, basically we are mainly working. Justosis is an organization, it's an international organization, and I am the president of India Association of Justosis. And Justosis is the organization which is working exclusively on pregnancy complication and mainly on hypertension disorder in pregnancy. And we have seen that there are a lot of screening tests are available across the world. We can say nearly 60 tests are available for screening of GDM, HDP, sorry, for screening of HDP. But then ultimately all the guidelines, ACOG, RCOG, FIGO, FOXY, all the guidelines suggest important role of presence of high risk factors. And from these high risk factors, after a hard work of nearly 1 year, Justosis has prepared Justosis score. And with the simple application of Justosis score, we can come to know, we can predict 80 to 84% possibilities. We can predict possibility of having a HDP in 80 to 84% of pregnant women, which is far equivalent to our sonography study, color Doppler study. So there are a lot of now, and Justosis score is also now across the world. It also going to is regularly now going to recognize. In Tamil Nadu, government has also made it mandatory to follow this Justosis score in all the medical colleges. So there are a lot of updates, new things, simple things. Now there are no confusions and very straightforward from definition to classification to screening methods, and we need to learn all these things. So I am really happy to see that today the committee of AMOGS has selected these two topics, and I am happy to see that our 4 societies of our North Gujarat are jointly organizing this event. So once again, I would like to congratulate president secretaries of all 4 societies. We have a list of eminent faculties and panelists with us, and I'm not going to take names of all the panelists because otherwise it may take a long time of all of you. But I would like to congratulate Sarfraz, Archana, Monica, Sneha, of course Kiran, my dear friend, president of AMOGS, and all of you. I wish best wishes for the success of this webinar. And once again, thank you very much for giving me this opportunity and honor. Thank you.
Thank you, sir. Thank you so much. And of course, I I know all of you are blessing me already. Once again, I request for this. Thank you so much. Maybe ask Dr. Monica to introduce Dr. Kiran Kurti and
Yes, ma'am. Our chief guest for today, the president of AMOGS, Dr. Kiran Kotri, sir. Apart from the academic achievements, sir has been the constant encouragement behind all the work that has been done in AMOGS, and sir has never said no to anybody who has approached him.
Monica,
Yes, sir.
okay. Monica, thank
So
you.
that is why I didn't read a single word from the
Don't worry,
slides, sir.
Don't worry. Thank you so much.
Yes,
At the outset, a warm welcome on behalf of AMOGS to everyone. my friend, brother, philosopher guide, Dr. Alpesh Bhai. Thank you. And many of you do not know, but it is Dr. Alpesh Gandhi who had suggested the concept of high risk pregnancy unit or HDU in obstetrics. So this was, I know, Dr. Alpesh, when it was Corona times, but it was your suggestion. And many of you may not be knowing, but a 10,000 page booklet or book, not booklet, book of Dr. Alpesh is available on HDU, management of all patients in HDU house to set up a HDU in obstetrics. So Alpesh bhai, thank you so much. Remember your presidency to the T. Thank you so much. And definitely the justice
Thank you,
score.
Kiran.
Yeah. And the Gestosis score, Dr. Alpesh bhai, we have always propagated the Gestosis score. It has been shared by one of our members, Dr. Gorak. You know Dr. Gorak Bandrupkar, and all the societies have been given score so that they can implement it in their day-to-day practice. So thank you so much, Alpesh bhai, for that. Our also guest of honor, Dr. MC Patel. Thank you. Dr. MC Patel deserves a he's a big name in Foxy everywhere. Everywhere we go, a lot of medical legal issues are handled by Dr. MC Patel. Whenever there is an issue, it is handled. And recently, what has happened is not only Pune, but the entire Maharashtra has been rocked by 3 maternal deaths. And all these 3 maternal deaths are related to hypertension and PPH. So in this situation, not only people like Sneha are very important, Sneha, Monica, Archana ji, Dr. Saxena madam, everyone, they are important because they chair these committees. So on one line, we have to propagate how to improve the quality of care, antenatal care. And on the other hand, in case we get into trouble, we have people like Dr. MC Patel to bail us out because you have handled everything. You have handled everything. But ultimately, if there is a police case, what are you going to do? Ultimately, it is the doctor who has to face. Earlier, it was only number बदल गया है 304A का बदले 1061 हो गया है. नंबर बदलने से तकदीर नहीं बदलेगी. Number still बदल गया है. The fate is the same. The doctor has to face criminal charges. And not only that, as a matter of fact, when we were discussing with the commissioner, what kind of mental trauma that the family of the doctor, the parents of the doctor, the children of the doctor may be going through, that is unimaginable. So, Dr. MC Patel, your role is also very important. As a matter of fact, AMOGS has gone a step ahead, and we have requested Sudhir Babu Mungantiwar, and also we are going to make shortly a presentation to the CM also and to the Health Ministry also, that wherever possible and whenever possible, each and every pregnant patient should be examined by a qualified gynecologist at least for 5 times in her antenatal period. At least 5 times. So wherever that gynecologist is available, there may be few places where a gynecologist may not be available. In that case, that he will be taken care by other pathy doctors. That is fair enough. But wherever a gynecologist is there, in case the government makes it mandatory to be examined by a gynecologist at least 5 times in her antenatal period, then I think the maternal morbidity and mortality can be taken care of. So I guess, thank you. And thank you, Himmat Nagar. I see Sarfaraz, a dear friend, and I see everyone's, Sarfaraz is there, Patan, Mehsana. I have been to Mehsana n number of times. Patan, Vyomesh, when the name of Patan comes up, I have been to Patan for about a month or so, learning with Vyomesh. So thank you, everyone, and thank you, Sneha. You have not only bound together all the AMOGS, I would not say category C societies, but small societies, let us say. Okay, small societies. The same way you have got the small societies of entire Gujarat, and you are doing programs. So thank you so much. And AMOGS would always love to partner with Gujarat in all kind of activities which are good enough for the well-being of the maternal health. So thank you so much, and wish you all the best.
Thank you, Kiran. Thank you.
Kiran, you are doing good work as the president of AMOGS, and I know Pune Gynec Society and AMOGS stood strongly and unitedly with this event. At any time, we all are with you, and if you require any help or any support from all our societies, we are also with you.
Yeah. I also acknowledge my dear friend Dr. Sushila. Shara. Sushila, can you hear me? I acknowledged you. Thank you. Thank you for being with AMOGS.
I think she's not able to unmute, but
Yeah, it's okay. It's okay. She heard me. I'll be talking to her. Please carry on.
Yeah. Hi, Kiran. Sorry. I couldn't unmute for a minute there.
Sorry.
Yeah.
Sorry. Please carry on.
Thank you
Thank
so
you.
much. So may we invite Dr. MC Patel, sir. Yes, Sarfraz, please go
Yes,
ahead
ma'am.
with first introduction.
Yeah. First of all, I also introduce to you Dr. Rachna ma'am, who is my co-convener. I'm looking gorgeous with perfect specs.
Oh God. Thank you, Kasi, for that. Thank you so
I will
much.
give
It's
you this
always a
opportunity to introduce. Dr. Rachna ma'am is right now the chairperson of Midlife Management Committee, and she was the past president of BUGS. Ma'am, this is your opportunity to introduce MC Patel sir, please.
yeah. So I think I feel very privileged when I talk about Dr. MC Patel sir and being in Gujarat and Pan India. I would slowly think about Pan World also. He's the most friendly person whenever you call him. Other than academic achievements, I would like to tell that most friendly person. At the middle of the night, also, if you call and seek help, he's always there. As Dr. Kiran sir already said, that whenever required, we need MC Patel sir to take us out, to bail us out in whatever blunders sometimes which may happen. So it's a proud privilege to have you, sir, in on this platform. And rather than reading out the CV, I think I
We
would
would
like
like to
to
listen to you.
hear from MC Patel, sir, because all his words sounds like a wisdom to all of us.
It's
Over
okay.
to you, sir.
Archana, it's okay. So thank you, Archana, for kind words. And let me congratulate first Emergency Obstetric Committee, AMOGS, Dr. Kiran, and this is the committee headed by Dr. Sneha Buyar for selecting very interesting topic. And before that, they have involved our Sogo, North Gujarat Society, Mehsana, Patan, Palanpur, and Himmatnagar. So I thank you for the same. And you have very rightly chosen the subject for discussion. Because I many a times called, these are the two major killer, brothers and sisters in obstetric. Hypertensive disorders in pregnancy and GDM. And you have nicely chosen good faculty for the same. As far as Dr. P.K. Saxena is concerned, she has pioneering work in GDM. She has her own publication and it is very useful to our obstetrician friends in day-to-day practice. So I again congratulate Sneha for the same. And one more learned speaker, Dr. Sushila Rani. She is also going to justify the subject very nicely because I have heard her for the same topic in past also, and she is master as far as this topic is concerned. And panel HDP, naturally, how to predict, how to prevent, and even in spite of all our care and caution, if we cannot predict, cannot prevent, then how meticulously manage or treat that very patient as far as HDG is concerned, because these both are major killers as far as maternal mortality is concerned. And we are very keen to challenge this maternal mortality because by 2030, WHO and Government of India has given us a target to keep maternal mortality less than 70, 67. Of course, few are the states who are already in a good position, but two states I would like to mention. One state is Assam, which is near 200, and second is Madhya Pradesh. So in this situation, if we tackle both this brother and sister, that is HDP and GDM, then it will be a great help or great job we will do as an obstetrician as far as checking of this MMR is concerned. So again, congratulating Dr. Sneha and of course Monica, Sarfaraj, Archana, yeah, they are coordinator and convener, and all the learned chairpersons and panelists from our own Sogo. So thanking you again, Sneha, and all the best for your endeavor in Foxy. I would appeal all the Society of Sobog and all the delegates who have joined this webinar. She deserved candidate as far as post of Vice President Foxy West Zone is concerned. And at the same time, I would also say a word for Monica also. She is also going for Public Awareness Committee this year as far as Public Awareness Committee Foxy is concerned. Both the candidates are very deserved candidate for respective posts, and I appeal all the delegates and all the faculties who have joined this webinar to support, to nominate, and to help to reach their goal in FOXY. Thank you very much.
Thank you, sir.
Thank you,
Thank
sir.
you. Thank you so much,
for
sir.
your blessings, especially. Of course, we need your words and your prayers also. Thank you so much. So
Yes, sir. I think Sneha ma'am, you are very well deserving, as sir already said. And
Yes.
when we talk about PSC, I think only Monica is visualized to us.
Yes.
So she is
Yes.
Thank
very
you so much,
hardworking.
ma'am.
And AMOGS is such
Monica
an
ma'am is going to
opportunity.
be unopposed.
નહીં નહીં સર ઇલેક્શન થશે
Any
નહીં થવા
letter
દેવું.
ઇલેક્શન
hope,
થશે નોમિનેશન પૂરા થાય ત્યાં સુધી બે નામ આવ્યા છે હવે
Kaji,
અચ્છા, એવું છે.
let us hope she should go
yeah,
unopposed.
let us
Yes, let us.
say that she
But-
should
but
go
if at all there is
uncontested. That is
election,
what I will say.
If
Yeah.
at all there is election, let us see, she should be through.
Yes.
થેન્ક યુ
Yes,
થેન્ક
yes.
યુ સો મચ સર થેન્ક યુ
Thank you so much, everybody. My special thanks to Dr. Kiran Kurtakurti, AMOGS President, especially for allowing us to go ahead with whatever programs we decide. Of course, Dr. Alpesh Gandhi sir, who is my mentor in FOXY right from my first entry to FOXY, and Dr. MP Patel sir, who is a constant mentor and guide to actually handholds us, to go through any condition. So thank you so much, all the esteemed faculty, especially Dr. P.P. Saxena, Dr. Sushila Rani, and my conveners and my dear friends, Dr. Archana Dwivedi and Dr. Sarfraz Kazi, coordinator Dr. Monica Umbadan, all the president secretaries of the Patan, Palanpur, Himmatnagar and Mehsana societies of Gujarat. Thank you so much for your association, and let us now continue go ahead with the academic session. With this, I thank everybody, and please, Monica, I hand
Yes,
over.
ma'am.
Thank you so much.
Thank you, ma'am. Thank you for allowing us, all three of us, to coordinate this program. And thank you, Alpesh sir, Kiran sir, and Patel sir, for gracing the occasion. Sarfaraz sir, would you like to take the first session?
Yeah, no problem.
Yes.
So for our first session, I would like to invite our two chairperson, Dr. Sanjay Gandhi sir, past president of Palanpur Society, and he is right now very busy in his family programs, but he is always ready to join any academic, and he never says no. Thank you very much, sir, for coming.
Sarfraz, it is okay.
Hope your health is also good, sir.
It is okay. Thank you. For
And our next second chairperson is Dr. Prakash Joshi, sir, senior most gynecologist from the Himmatnagar, and he is the best photographer, and he got one best photographer award recently. Welcome, sir.
Welcome, Dr. Prakash. Welcome, Dr. Gandhi.
Yeah. So I would like to invite Dr. Sanjay Gandhi, sir, to introduce our first speaker. Sanjay Gandhi, sir, unmute karo.
Yes. I welcome Dr. P.K. Saxena from the Obstetric and Gynecology Department. She is a very long list of the achievements. Okay, she is director and head of the unit of SSKH, New Delhi. She is a winner of 34 gold medals. My God. In national and international conferences, editor of 11 books, published 250 articles, chairperson of AOGD and Infertility and Reproductive Committee in 24 and 26, national coordinator of FOXY Committee in Medical Disorders in Pregnancy, convener SIG of Early Pregnancy Infertility Society of Fertility Society. Yes.
Thank you so much for giving very nice.
Yeah, she's General Secretary of Board of Management of Delhi Diabetic Forum. Very nice. Thank you. Welcome.
Thank you.
Yeah.
So, first of all, I would like to thank Dr. Sneha for giving me the opportunity to be here and share my views regarding this very important topic on, am I audible?
Yes, madam.
Yes, ma'am.
a very important topic on screening and diagnosis of gestational diabetes, controversy to consensus. So, Dr. Sneha, I think you are doing an excellent job. It is not so easy to carry on 39 series, and you have been consistently working on high-risk pregnancy. And I've seen you for so many years working in Foxy day and night, and you are a really very friendly, very humble person. And I wish you all the best. And wishing all the best to Dr. Monica also for the elections, forthcoming elections. And my respects to both the chairpersons, conveners, and all the presidents and secretaries, the co-faculties, panelists, and everybody. Thank you so much. So my throat is not very good. So pardon me if I'm not able to speak too much. And I will be just starting. Out of 127 million live births every year, 21 million are complicated by some form of hyperglycemia. 3 to 4 million out of this are only detected and treated, and a negligible number receive postpartum follow-up and lifestyle advice. So the biggest challenge here is to unmask the already existing hyperglycemia during pregnancy, which is the first and the foremost crucial step to curb the diagnosis, the epidemic. If we don't know whom to screen and how to screen, we will not be able to pick up the persons who are suffering from hyperglycemia, and we will not be able to prevent the feto-maternal complications and the long-term complications. So very briefly, there are so many terminologies which are used for hyperglycemia in pregnancy. This is the new term which is being used now all over the world, given by FIGO in the beginning. So it is of two types. I will just take a pointer. So it is of two types. There is diabetes in pregnancy and gestational diabetes. This diabetes in pregnancy is also known as pre-gestational diabetes or overt diabetes, and this may be type 1 or type 2. When do you say that the woman has diabetes in pregnancy? If fasting blood glucose is more than equal to 126, or if the random or 2-hour post glucose is more than equal to 200. These are the same threshold values which are used in non-pregnant patients to diagnose them as diabetes. And GTM is a condition where the threshold is below this. Because this is a slightly a condition where the insulin resistance is mild. So whenever the threshold 2 hours after post-glucose load is between 140 to 199, we say that the woman is having GTM. And mind you, now GTM is detected in the first, second, and third trimester, all the trimesters. So the novel concept of primordial prevention of diabetes mellitus was given by Professor V. Seshaya. And I think maximum number of work, the research studies which have been coming from India are from the DIPSI group under the guidance of Dr. Seshaya. He's also the father of GTM in India, and his birthday, 10th of March, is celebrated as the GTM Day. I'm very lucky that Sir has included me and made me an important member of the DIPSI. So coming to some recent changes, the patterns of glycemia in normal pregnancy were studied, and this is a paper from the American Diabetes Association. Should the current therapeutic targets be challenged? And there was this Hernandez et al., which have done a study by pulling analysis of 12 studies over 45 years of data in normal glycemic women. And what they found was that the fasting should be lowered down to 71 plus minus 8 as compared to the 95, which is recommended in most guidelines at present. And the 2-hour value postprandial should be less than 120 as against the 120, which is being followed right now by most of the guidelines. In sync with this, the DIPSI guidelines to 2023 revised DIPSI guidelines have come out, and GTM, as we know, is 2 hours post-glucose value more than 140, and these women are prone to develop risk in the pregnancy itself, and also they are prone to develop type 2 diabetes mellitus later on in life. GGI is the new term introduced, where the 2-hour post glucose value. This is after 75 gram glucose. If it is between 120 to 140. 140 and more is GDM. Between 120 to 140 is GGI. This is the gestational glucose intolerance. And these women, it has been observed that these women are also prone to adverse fetal-maternal outcome and future risk of type 2 diabetes. And the third category, this is the one we are concentrating on to prevent development of GDM. So in this, when the woman comes to us between 8 to 12 weeks, 2 hours postprandial, this is not after post-glucose, if the value is more than 110, we have done a big study in Delhi where we found that nearly 98% of these women are prone to develop GDM as the period of gestation increases. So I think GDM is a very controversial topic, and the most controversial one is the eternal controversy on screening and diagnosis of GDM. So I think it is very clear that the pragmatic guidelines for testing should be based on the finances available, human resource, and the infrastructure resources which are available in the country. The Caucasian guidelines, maybe they are not relevant and cannot be practically followed in a country where the women are still coming to us. I'm sitting in New Delhi in the heart of the country, and still we are getting pregnant patients who are unbooked, who have not got any hemoglobin done, who have not got tetanus toxoid done. So going for tests 3 times, 5 times testing during pregnancy, coming in a fasting state, it is not practical and feasible for most of the people staying in the rural areas and also in the metropolitan cities. So what is the benefit? Why should we screen? I think there is no controversy here. We know that the women with GDM have an increased risk of fetal-maternal complications. 2/3 of these are going to develop GDM in the next pregnancy, and 50 to 70% are going to develop type 2 diabetes in 2 to 5 years. About their children, they are also prone to develop fetal-maternal complications during pregnancy, and as they grow up, they have undergone intrauterine programming, and so they will also be developing obesity, childhood obesity, impaired glucose tolerance, diabetes mellitus, metabolic syndrome, and all the NCDs, because GDM today is the mother of all NCDs tomorrow. So GDM gives a unique opportunity for initiating the strategies for preventing not only immediate pregnancy complications, but also future NCDs and diabetes. Now, there are about 11 guidelines, and everyone has a different opinion who should be screened, how they should be screened. So for Indian scenario, whether it should be a universal or a selective screening. So here we know that Indian women are 11 times more at risk of developing glucose intolerance. So universal screening is the one which is recommended in the national guidelines of India. This universal guideline, universal screening is also recommended by DIPSI, FIGO, International Association of Diabetes in Pregnancy Study Group, ACOG, and ADA. It is only the NICE guidelines which recommend selective screening. Why so? Because probably the prevalence and the magnitude of problem of hyperglycemia in pregnancy is much lower in the Europe and also America. So they don't recommend screening of all women. They recommend only high-risk women should be screened. So what are the high-risk factors for developing GDM? So we have number of studies, and there's another study by Dr. Shaya where they found that age more than 25, BMI more than 25, family history of diabetes these are the women who are more prone to develop GDM. This is our own study published in the Journal of Obs and Gynae of India, where we found age, BMI, family history, history of abortions and stillbirths. I think women who are having dyslipidemia, who are having hypertension, medical disorders of pregnancy, previous stillbirths, macrosomia, and IUDs or abortions, these women are much more prone to develop GDM in the subsequent pregnancies. So when should screening be done? Should it be done at 24 to 28 weeks, which was recommended in most of the conventional textbooks, or should we start in the first trimester? This is the next question. So we have now sufficient robust data. This is a study where more than 4,000 women were screened, and the prevalence of GDM was found to be 17.9. I think in Delhi, in my institute, Lady Hardinge Medical College, we are testing all the women with DIPSI, and what we are finding is really alarming. Nearly 40% of the women who are coming to the antenatal OPD are suffering from hyperglycemia in pregnancy. And now the type 2, type 1 diabetes has also increased from 10% to nearly 20%. So we are really facing a big pandemic of GTM and or hyperglycemia in pregnancy. So as you can see in this table, nearly 38.7% developed GTM before 24 weeks. So in a hyperglycemic woman, each islet cell of the pancreas of the baby develops at about 10 to 11 weeks. If there is maternal hyperglycemia, it is going to go across the placenta, stimulate the beta cells of the placenta to secrete more insulin, result in macrosomia, and later on there is intrauterine programming, early metabolic imprinting, which will affect fetal growth. And this is the basis of the Barker's hypothesis. It says that the adult disease originates in the fetal line. So, should we go for one step or two step? What the evidence says, it has been seen that two-step approach will miss nearly 25% of patients, and that is why one-step screening has been endorsed by WHO, IADPSG, FIGO, DIPSI, and NICE guidelines. It is only the ACOG which recommends the Carpenter-Houston or the NDDG criteria, and here the woman has to come in a non-fasting state for the first visit, and there they give them a glucose challenge, and if the blood glucose is more than 140, then they are called for a second visit. When they are in a fasting state, 100-gram glucose challenge is given to them, and then we measure these blood glucose values and the fasting 1 hour, 2 hour, and 3 hour. And if any of these two values are above the threshold, then she is labeled as a GTM. Then we have WHO 1999 criteria. This is a very important criteria because this is the one which is followed in non-pregnant patients and also in the postpartum period when the woman is going to come at 6 weeks. We are going to follow up her with not the DIPSI test, but WHO 1999 criteria. Our DIPSI criteria has been adopted by the national guidelines in 2018, and the threshold is 140. IADPSG criteria, which was given in 2010, is now adopted by American Diabetes Association in 2011 and WHO in 2013. DIPSI criteria and the IADPSG are the two criteria all the postgraduates and the clinicians need to know. And in the IADPSG criteria, the woman has to come in a fasting state, and the fasting threshold, if it is more than 192, and she is given a 75-gram glucose challenge. All the tests recommend a 75-gram glucose challenge, except for the ACOG, Carpenter-Houston, and NDDG criteria. And the 1 hour threshold is 180, and 2 hours is 153. And if any one of these three is elevated, then she is labeled as GTM. The NICE guidelines gives the threshold of fasting as 101 and again 2 hours at 140. So I have highlighted here that out of these 5 important guidelines, 3 of them are recommending 140 as the threshold at 2 hours. So what is the rationale of giving 140 as the cutoff value? So I would just like to reiterate here that GTM is a condition of chronic beta cell disorder, and when there is a loss of beta cell disorder to 30 to 50%, it is coming out as impaired glucose tolerance test which is more than 140 in non-pregnant state. And this is a red flag at that time. So it is imperative to consider the same value as abnormal in gestational diabetes during pregnancy also. So the IADPSG criteria is based on the HAPO study, which was done in 23,316 women over 6 years in 9 countries. And what they found was that there was a continuous positive correlation between maternal glucose, all the 3 values, fasting, 1 hour and 2 hour, and the adverse feto-maternal outcomes like birth weight, cord peptide, and need for cesarean section and neonatal hypoglycemia. However, the most important point to note is that adverse feto-maternal outcomes were observed at levels even below the diagnostic cutoffs given by the IADPSG, which were set up as odds value of 1.75, whereas the DIPSI value, the threshold of 140, the odds ratio for this is 1.5. And the international guideline says that 2-hour glucose cutoff value of 153 selected by IADPSG may not be efficient in identifying women at risk for fetal overgrowth as compared to 2 hours value of 140, which is the odds ratio of 1.5, which is the same as given by our DIPSI guidelines. There are some shortcomings of the IADPSG criteria. It has not included the Southeast Asian population.
लक्ष ठेव बरोबर समोरच थांब मी वर जाऊन येते ठीक आहे ना ठीक आहे बाकी
Antenatal patients do not generally come in a fasting state. Fasting value that they have said is not reflective of the postprandial values. And the low threshold that they have kept increases the workload, and we get different results in different centers. The advantages of using the DIPSI guideline. Excuse me, can you please mute everybody? So the advantages of doing universal testing by GDM, of GDM by DIPSI test, which is also recommended by the national guidelines, is that it is the only test which is most convenient and practical, can be done irrespective of fasting status, can be done as a point of care by a glucometer, so there is less chances of lost to follow up. It is easy, convenient, only one sample is drawn, cost effective, and it not only serves as a screening, but as also a diagnostic procedure. So this is a very important paper which was published by, again, the DIPSI group, V. Balaji and Dr. Shaya group, where they have found they did the comparison of venous plasma glucose with glucometer, which is testing the capillary blood glucose, and they found that it is quite accurate. The specificity is 98% and the sensitivity is 80%. So plasma calibrated glucometer has been recommended by the national guideline also, and it is endorsed by FIGO 2015 also. What should be the frequency of testing? So again, we have so many guidelines which are recommending once, twice, 3 times. The DIPSI guidelines recommends 3 times. However, the Government of India guidelines recommends in the first visit and 24 to 28 visit. So the question comes, why DIPSI is recommending 3 times? So again, we go back to the same study and we see that nearly 29% of women who were normoglycemic in the first visit are diagnosed at GDM during repeat testing in subsequent. And here you can see more than 30 weeks, 20.7% were diagnosed as GDM. So what we do in my clinical practice, all the high-risk women, the things that we discussed in the beginning, obese, women with PCOS, who are having hypothyroidism, who are having high blood pressure, who have a previous history of GDM, stillbirth, macrosomia, or IUD, or family history of diabetes. All those women, wherever you are having a strong suspicion, please do test in the 3rd trimester also, and you will be able to pick up few patients there. And it is not very late to start the treatment at that time. Coming to the scientific validity of DIPSI, some people are always questioning the scientific validity of DIPSI. So this was a study done by us in Lady Harding, where we compared the DIPSI guidelines with the WHO OGTT in 800 women, and we found the prevalence of GTM in 2017 to be 6.25%, but the diagnostic accuracy and the kappa value, that is the agreement between the two tests, was also very good at 0.868. Diagnostic accuracy, positive, negative predictive value was excellent for DIPSI as compared to WHO GTT, and also it was found to be more sensitive as compared to HbA1c. This was another landmark study which we did in Lady Harding, where we compared the diagnostic accuracy of DIPSI with the two age-old parameters of ACOG, Carpenter-Houston, and NDDG. So this was done in 1,029 patients, and the prevalence of GTM by DIPSI was 10.4, 6.4 by Carpenter-Houston, and only 3.1 by NDDG. Mind you, these are the two criteria recommended by ACOG, and see how much is the difference between the two criteria given by the ACOG itself. NDDG missed nearly half of the cases who were diagnosed by Carpenter-Houston. And ours was the first study to show that the women who were diagnosed as GTM by DIPSI criteria also had a high rate of cesarean section, mean birth weight, and macrosomia, which implies that DIPSI correlates well with fetal-maternal outcome, and the diagnostic accuracy of DIPSI was more than 95% with both Carpenter-Houston and NDDG. So these are the studies where we can see this is such a good scientific sensitivity, and specificity is excellent for this test. Only 2 studies found that the sensitivity was less. Otherwise, all other studies have found a very good sensitivity. So the current status of DIPSI is that the National Guidelines 2018 recommend DIPSI. It is also recommended by our own FOXY Society, Endocrine Society of India, Indian Society of Neonatology, RSSDI, Association of Physicians of India, API, International Diabetes Federation, and FIGO, International Federation of Obs and Gynae. It is the most pertinent test in the new COVID world. So it is a one-step test for universal screening and can be done as a point-of-care testing. Just a few words about HbA1c. You can see that diagnosis of diabetes is made when HbA1c is more than 6.5%, fasting is more than 126, or 2 hours is more than 200. Pre-diabetes is from 5.7 to 6.4%. Impaired fasting, we say when the fasting level is between 100 to 125, and impaired glucose tolerance is when 140 to 199. Normal is all values below this. It is not, it is recommended that HbA1c should be done only in the first trimester to distinguish between pregestational diabetes and GTM. Otherwise, it is not a very sensitive marker because the RBC lifespan is short and the women are already suffering from anemia. There are so many hemoglobinopathies. It is an expensive test and it gives an idea about 3 months. Although in diabetes, in GTM during pregnancy, we need to control it every day. So we need a test which can give us results in 1 day. That is why it is not very accurate marker. WHO does not recommend monitoring by HbA1c, but it helps to distinguish between diabetes and GTM. And also, if the level of, as the level of HbA1c increases above 10%, the chances of congenital anomaly are nearly 25%. So it is very important that if it can be done in the first trimester, it gives us straight away an idea how to manage these patients. If it is higher, then of course that means it is a severe insulin resistance, and we have to straight away start with some pharmacotherapy along with MAT. We don't need to wait for 2 weeks. So coming to the consensus, we had debates on many issues. I think now we agree that there is a need for a simple, cost-effective, outcome-based diagnostic test. Universal screening should be done for all women. Early screening should be done in first visit, and high-risk women should also be, if found negative in the first visit, should be tested in the second visit, in the second or the third trimester also. One-step test by venous or by glucometer is accurate. Frequency of testing, I have already talked about it. And DIPSI, I hope the debate is now settled in the favor of DIPSI, but I say that any test should be done. Universal testing should be done. Whatever test you want to do, DIPSI is the recommended one and the most appropriate for our country. But if you are in an affluent center, you are a private practitioner, you can also go for IIT PhD. So I thank you all for a very patient hearing. And these are some of my books on diabetes, clinical guidelines for management of diabetes in pregnancy, managing hyperglycemia. Dr. Sushila Rani is a co-author in this. So thank you all for a very patient hearing.
Thank you, madam. In a very nice elaborative lecture.
Prakash Joshi, sir, closing comment from your side.
Prakash bhai.
Prakash bhai.
Sir, you are muted.
Joshi, sir, please unmute yourself.
Hello. Madam, thank you so much. You put the subject, which is very big in size, into your fist, and then you explained excellently. But there are a few points to say that whenever a patient with PCOS conceive, that always keep a vigil, especially obese PCOS as compared to the thin lean PCO. Thin lean PCO are not likely to get much diabetes as compared to the obese PCO. And secondly, we should have some collaboration with our physician friend that they are having no idea about the one-step test as advised by the DIPSI. So sometimes when refer the patient for control of the diabetes, they subject the patient for two-step test, that is a 1 hour, 2 hour fasting. And lastly, we need to say something to the pathologist friend that when they ask the patient about the history, then the patient is saying that I have taken my lunch and I am subjecting myself for blood glucose test after consuming 75 gram glucose. So they are also not aware of it. Otherwise, the things are very close to control if we keep vigil on each and every patient. And we keep vigil in our community that each and every patient is likely a candidate for the diabetes in the future. So it is as good as to see hemoglobin, blood group, and all the things. So thank you so much for the excellent participation, for the knowledge. Thank you, madam.
Prakash has raised a very important point. It is not just the physicians, but the dermatologists, the gym people, and ourselves in the adolescent clinic, in the infertility clinic. All women coming with PCOS, we must do a ODTT and see if she is having impaired fasting, impaired glucose tolerance, or diabetes, and start them on metformin. And sir, here I would like to make a point. It is not just obese. Even lean PCOS woman may be having insulin resistance. And if that is present, or if she has surrogate markers for insulin resistance like obesity, acanthosis, hirsutism, and if her impaired glucose tolerance test is there, then we need to continue her on pharmacotherapy. It is very important to screen and follow these women under close scrutiny of the gynecologists, of the obstetricians. Very important point made by you.
Thank you. Thank you, madam.
Madam, can I ask one question?
Sure. Yes, Sanjay sir.
Yeah, if it is under control up to full term, still there are chances of unexplained IUDs.
So this is also a very important thing, and many times we have seen that patients are having normoglycemia, but they are having polyhydramnios or macrosomia. I'm sure all of us, or they have sudden IUDs. So what happens is there is a procedure, there is a phenomena which is known as fetal renal glucose steal phenomena. So the threshold of the kidneys of the baby is 110. If the mother's blood glucose is more than 110, the fetal pancreas are going to produce more insulin. So if the baby is hyperinsulinemic, it is going to pull the mother's glucose into the baby's circulation. And the mother's glucose values come out to be normal, but it is at the expense of the baby. And this has been proven by measuring the amniotic fluid insulin. And they found that this is a surrogate marker of hyperinsulinemia of the baby. Any baby who is having hyperinsulinemia has undergone intrauterine programming, and they may be any time be suffering from stillbirth because of hypoglycemia, electrolyte imbalance, ABG, and they have chronic hypoxia when they go into labor, and sometimes otherwise, and they are associated with chronic hypertensive disease also. I'm sure Dr. Sushila is going to elaborate on that. And no matter whatever test we are doing, daily fetal movement count, NST, biophysical profile, Doppler, everything comes out to be normal. But suddenly, unpredicted fetal death occurs, stillbirth occurs. So it is very, very common because in some of these women, we find that the sugar levels are normal, but the signs are that if she is having high increased amount of liquor, macrosomia, IUGR, that means she has severe metabolic dysfunction, and these women may suddenly come up with intrauterine death or stillbirth.
Thank you.
Madam, one more question. That
Yes,
in some PCOS, we are advocating the patient to continue metformin for a very long time. Say
Yeah.
some people advocate for 3 months, 5 months, 6 months. So in that case, sometimes even while subjecting the patient for detection of the diabetes, there is a masking of the diabetic activity because the patient is already on the metformin. So
Yes.
once we stop metformin, then we need to subject the patient for the test of glucose after 15 days or 1 month. Then they start developing the gestational diabetes.
I think this is the most important question in each conference. We are discussing the same thing. So, sir, in this, I would like to say that the woman, we have put her on metformin because she's already having insulin resistance.
Right.
During pregnancy, the glucogenic hormones will be produced, which will make her blood sugar levels go higher. If we stop metformin at this time, she is going to have even higher blood sugar levels. So it is important that in these women, we can do just fasting and PP to see whether it is, and or the 7 sugar profile to see whether she is having controlled glycemic, because if we stop metformin, her glucose levels are going to increase. And first trimester that we talked about is the most important period in which if there is hyperglycemia, the intrauterine programming will occur. Macrosomia sets up in 12 to 14 weeks of gestation. So we cannot let that problem occur in our women. So it is better to continue metformin, and we can just follow the fasting and postprandial glucose, or even if we subject to 75 gram glucose and we find that it is more than 140, we can start her on MNT also along with that, and keep a vigil by doing fasting and 2 hours postprandial frequently. And if it exceeds the target values, we can increase the dose of metformin or transfer her to insulin, because they are very, very high risk patients.
Okay, thank you, madam.
Thank you, sir.
Yeah, thank you so
very
much,
much.
Dr. Picky. That was an excellent talk, and I'm sure Dr. Sushila will be covering all these minor details in her talk on management. I think we can go ahead, Dr. Sarfraz.
Yes,
With the next
ma'am.
talk. Thank you,
Thank you very
Chairperson
much.
Dr.
Thank you
Sanjay.
very much, Vicky ma'am. Thank you very much, the chairperson.
Thank you. Thank you.
Sir, sir,
It was an excellent talk. Monica ma'am. તમે આપો.
Thank you. Can we have the slides? Now, after listening to PK Madam, almost all the our doubts about pathophysiology things have been cleared, but we have been blessed with a very good speaker, Dr. Sushila Nani Madam, who will be speaking on tackling hyperglycemia in pregnancy. Our chairpersons are Dr. Mukund Patel sir and Dr. M.D. Soni sir. Can we have the slides, please? Dr. Mukund Patel sir is an assistant professor at the GMRS Medical College, Patan. Sir had started his private practice in 1993, and he has been a part of various conferences as a faculty. He has been the organizing secretary of the Gujarat State IMA Conference at Unja and the vice president of GSB IMA Gujarat. Sir is currently the president of Mehsana OBGYN Society. Sir, we welcome you as a chairperson for this talk. Our next chairperson is Dr. Mahendra Soni, sir. He had hosted the SOGOG conference in 94 and 23 as a chairperson. He has been the past president of SOGOG in 95 and 24, the founder president of Himmatnagar Obijawai Society. He has participated in many conferences and trainings. He has been the ex-regional chairman of the Lions Club International. We welcome you, sir.
Thank you.
I request Mukund sir to please introduce our speaker for today, Dr. Sushila Rani Madam.
કેમ અનમ્યુટ કરવાનું કીધું?
Mukund sir, unmute કરીને બોલશો?
Mukund sir?
Soni sir, in the meantime, you can introduce, sir.
Yeah. So, Dr. B.S. Sushila Rani, she is a MD, PGDML and FICOG. She is a medical director and consultant at Manjushri Specialty Hospital, Bengaluru. She is a postgraduate teacher. She is a past president of Bengaluru Gynec Society and chapter secretary of IMS, chairperson of BSOG Postgraduate Forum. She is a winner of Vidya Basin Award and Best Teacher Award. So please, I welcome Dr. Sushila Rani.
Thank you.
Kaji, I am audible.
Thank you,
Yes, sir. Very much
everybody.
audible.
First of all, thanks to Dr. Alpesh, Dr. Kiran. Yeah. My thanks to Dr. Alpesh, Dr. Kiran, Dr. MC Patel, people I regard very high and who have done a lot of work for our society. Thank you, Dr. Sneha, for giving me this opportunity. And Dr. Monica and Sneha, my best wishes for your future endeavors in Foxy. And my respects to the chairpersons, Dr. Mukund Patel and Dr. Soni. I would straight away go to Yeah. Are my slides seen?
Yes, ma'am.
Yes. Yeah. So my topic for today is tackling hyperglycemia and pregnancy. So I'm going to stick to managing hyperglycemia and pregnancy because the other aspect is the obstetric management of a GDM. I'm given 15 minutes. I might stretch it by a minute or two, but not more than that. We will go into the pattern of glycemia and normal pregnancy. What is very, very surprising is that in a fasting blood sugar, when you look at non-pregnant people, you will find that the fasting blood sugar ranges anywhere between 90 and 126. And look at the fasting blood sugar in normal pregnancy, it is anywhere between 60 and maximum 80 and doesn't go beyond that. And a 2-hour blood sugar, you will see that it ranges anywhere between 100 to 110 in a pregnant woman, whereas the 2-hour blood sugar in a non-pregnant person can go up to 140 or beyond. So with this, I want to say that the blood sugars in normal pregnancy, I want everybody to understand that the blood sugars in normal pregnancy is far, far, far lower than what is seen in a non-pregnant person. So we cannot take even sugars like 100, 120, 130 that easy. So what are the targets of post-meal, whether it is post-breakfast, post-lunch or post-dinner, not more than 120 and a mean blood sugar of 95 to 105. What we are looking at birth weight of 2.5 to 3.5 kgs. Now, how do we bring the blood sugars under control? We have two different kinds. One, insulin resistance here and deficiency of insulin that happens in type 1 diabetes. In GDM, of course, there is an increased insulin resistance that is responsible for hyperglycemia. So glycemic control can be brought in by increasing the insulin production or by decreasing the glucose load, the load that is given to the body to dispose of, or by decreasing the insulin resistance. How do we increase insulin? Via drugs which will increase the production of insulin, like glyburide. How do we decrease the glucose load? We make modifications in the diet and thereby decrease the glucose load. How do we decrease the insulin resistance? Most important is exercise. And of course, drugs like metformin also decrease the insulin resistance. So this is how we are planning to manage the glycemic in a diabetic pregnancy. So, which are not drugs include diet modifications and increasing exercise. Now, this is primary. This is the basic and is the foundation stone for any management of hyperglycemia, whether in pregnancy or outside pregnancy. What are the diet modifications we are looking at? We need to reduce the grain size. So, no going beyond 2 numbers of either idli, dosa, roti, chapati, whatever, 1 soup bowl size of rice, upma, poha. And again, what should be the frequency of meals? We should say 3 small meals and 3 snacks. We should reduce the size of each meal and introduce one small snack in between so that there is no spike in the blood sugar levels. Protein sources which need to be compulsory include paneer, soya, dals, lentils, sprouts, boiled groundnuts, seeds, eggs, chicken, small fish, milk, etc. Now, things that definitely need to be avoided include bakery items, packaged food, and definitely biscuits. And fiber. Why should we increase the fiber? Prevent the release of glucose. Instead of a sudden high increase in the glucose levels, the fibers hold on to the release of glucose, and therefore the glucose release happens at a much slower level. Therefore, we need to include maximum non-starchy and colored vegetables. So our Indian meal is very high in carbohydrates and a little low on protein. We need to reverse this. We need to decrease the carbohydrate and increase the protein, and the protein content depending upon whichever part of India you're in. This is an example of the snacks that can be had, not the quantity though, but a description of the snacks. And this is the kind of a meal that can provide a high protein. Now, if we are in an institution where we don't have a dietitian, then an obstetrician will act like a dietitian, or we need to have somebody, one of our nurses or any help who is trained to do it. It needs to be explained to the woman that in very simple terms, if she were to take an 8-inch plate, then the half the plate should be full of vegetables, and quarter plate should contain protein, which can be in the form of dal, fish, chicken, etc. And a fish size of roti, rice, ragi, whatever forms the cereal, and very little ghee or oil. So that is how we explained. 8-inch plate, half vegetables, quarter protein, and quarter starch. And the starch comes from roti, rice, ragi, etc. Now, what are the exercises that can be done in pregnancy? People think once pregnant, no exercises. Well, the woman should be taken very good care of, etc., which is just the opposite of what is required or what is recommended. A 30-minute moderate intensity activity is recommended. Exercises can be aerobic and low resistance exercises. If they were planning to do exercises, an aerobic exercise also can be done, or anything with low resistance. One needs to make sure that they don't fall at any point of time. 15 to 20 minutes of moderate activity after a meal helps to keep sugar level within the target range. Since most women in India are not used to exercising, either during pregnancy or before or beyond pregnancy, the least that they can do is to incorporate 15 to 20-minute walk after each meal. This itself can bring down the blood sugars by 5 to 15 milligrams. So it can do a lot because the skeletal muscles mop up the glucose and bring down the sugar level. So 15 to 20-minute walk after each meal will go a long way. Preferably upper body low resistance exercises if you're working out in a gym. Now, mode is, like I said, aerobic walking, aquatic activities. Swimming is definitely recommended during pregnancy because it takes off the weight of the body and because of the buoyancy. Resistance exercises, low resistance exercises, weight training for arm muscles with half to 1 kg weight, and static resistance exercises like wall push-ups and wall squats can go a long way. So 30 minutes per session and at least 150 minutes of activity spread throughout the week. Start with a warm-up and then cool down as recommended. So these are, this is static sitting, this is a wall push-up, and these are some simple exercises that can be done during pregnancy. What is very important is most women who are working now are sitting in front of a system, a computer system, whatever, whether they are working in the IT sector or not. This continuous sitting or sedentary behavior increases the risk of neonatal outcomes, the risk adverse neonatal outcomes in GDM pregnancy, even in any pregnancy for that matter. Therefore, we need to encourage them to keep moving, get up and walk around your chair after every 10-15 minutes. This goes a long way in improving the physical activity. Now, pharmacological prescriptions include insulin, glyburide, and metformin. Now, these are the drugs that are used in pregnancy. All the others are not used because of their teratogenic effect. Now, the last that we got to know about glyburide is a meta-analysis, this paper, which says that association of adverse pregnancy outcomes with glyburide versus insulin in women with GDM. It says that there is an increased risk of and the baby, RDS, etc. And therefore, glyburide is out. So that leaves us with metformin, insulin for pharmacotherapy in GDM. This is a meta-analysis evaluating as many as 6,046 women. So it says that metformin is as good as insulin in the management of GDM. Now, what are the effects of metformins on the mother and what are the effects of metformins on the fetus? In the mother, it decreases the risk of miscarriage. This we have seen when we have used metformin to PCOS women, and when they get pregnant, we have enough evidence to say that it decreases the risk of abortions in these women. The risk is identical preeclampsia risk and identical cesarean birth. Gestational weight gain is reduced. It decreases the congenital anomaly. It said that metformin increases the incidence of preterm birth. The identical birth weight and height and long-term effect on the fetus. So there are some reports that there is an increased weight in the long term when children are studied up to the age of 14. Those mothers who received and their babies were studied up to the age of 14, and some of these babies showed an increased weight. So there's a beautiful article, Lights and Shadows on the Use of Metformin in Pregnancy from Preconception Phase to Breastfeeding and Beyond. I would recommend you to have a look at it. So metformin, according to our own of India, says metformin, it can be considered after 20 weeks of gestation for the medical management of GDM. The dose of metformin is 500 milligram twice daily orally, 500 milligram twice daily orally. And believe me, metformin has to be given after a meal, unlike most other drugs which are given before meal, like say iron, calcium, etc. Metformin is given after a meal, and the maximum dosage that can be given is about 2 grams a day. Now, which are those patients for whom we can prescribe metformin? Ideal candidates are those who have very little rise in the blood sugar level, say fasting blood sugar less than 100, or by the time you pick up GDM, they are at a gestational age of say 35, 36, 37 weeks, and there's no previous history of GDM, and women with a lower BMI, all these will benefit from metformin. The unique advantages of metformin is that it doesn't ever cause maternal hypoglycemia. It is very simple. No need to check the syringe and then look at asepsis, etc., and a host of other things that comes with insulin. It is easy to administer and definitely more acceptable for women. Patients who are more likely to require supplemental insulin, those women who are given metformin, might need insulin, and these are women who have a higher fasting plasma sugar, who earlier gestational age at the time of treatment. Supposing you've started metformin when she was around 24 weeks, or the diagnosis of GDM in previous pregnancy, obese women, BMI more than 35. These are women, even if you give them metformin, they will subsequently need insulin for the management. Now, the traditional management of GDM, that is over 100 years now, the management of GDM has been diet, exercise, and insulin. So there was safety in every step of the way. So when do we start insulin in a GDM? At diagnosis, along with MNT, if the sugars are very high, say the fasting blood sugar is more than 120, a 2 hours PPG is more than 200 milligram, this is a woman who definitely needs insulin. You can't wait for MNT to act and then start insulin. MNT and insulin are done together. Or supposing you've given MNT and you find still that the fasting blood sugar is more than 90 and the 2 hours post sugar is more than 120, that means MNT has not been able to control or bring the sugars to normal, then you add insulin. Now, how much insulin do we give in pregnancy? We know that in a woman who's got pre-gestational diabetes, that is type 1, type 2 diabetes, the requirement is 0.7 units in the first trimester, 0.8 in the second, and 0.9 in the third trimester. 2/3 is given in the morning and 1/3 at night, whatever, as a thumb rule. On the other hand, a gestational diabetes woman will require a very small dosage of insulin depending upon the time of onset of diabetes and the severity of hyperglycemia. Now, there are different kinds of insulin regimes, and this is dependent on whether she is a pre-gestational diabetic or type 1 or type 2 diabetes, or she has developed gestational diabetes. Now, in a woman who has got diabetes because of insulin resistance of pregnancy, the hyperglycemia is likely to be mild hyperglycemia. So once daily insulin may be enough. If fasting blood sugar is high, probably will give 2 times insulin. A premix insulin, that which contains a fast-acting and an intermediate-acting insulin. Fast-acting will act for that particular meal, and the intermediate-acting will last for about 10 to 12 hours. So that will take care of half the day. So that is how it works for a GDM. In a type 1 or type 2 diabetes, at least 3 injections of insulin daily, 3 injections covering 3 meals. And sometimes you might need to give a long-acting insulin at bedtime, like a detamir. Now, detamir is called as a peakless insulin. It covers the basal insulin requirement, whereas the rapid-acting insulins that we give take care of the blood sugars that come with each meal. So like I said, insulin mixtures come in 30-70 or 50-50, 30 of regular, 70 of isophane, or 50-50. So depending upon the requirement of the patient. So when I say multiple injection regimes, which includes, we give a mixed dose 30-70 in the morning and 30-70 just before a supper, or we give regular insulin, and at supper you give only a mixed insulin, or you give regular, and in the night you give one intermediate acting insulin. So these are different injection regimens. Now, I'm just giving you a sample. Say the fasting is 85, breakfast is 155, lunch is 145, dinner is 140. Our target for fasting is 90, so this is well below 90. Our target for post-meal sugars is 120. This is high, this is also high, this is also high. So what we can do here is just give 6 units of regular insulin before breakfast, before lunch, before dinner. So this will take care of the blood sugars that come with the postprandial rise. Now, dosage adjustment to achieve control. How do we titrate the dosage? Titration of dose is based on the self-monitoring of blood glucose level. If fasting blood sugar is more than 90 milligram, we'll have to increase the night dose of insulin by 2 to 3 units. If 2 hours post lunch is more than 130, then increase the morning dose by 2 to 3 units. In case of hypoglycemia, reduce 2 units both times. Hypo occurs if food is delayed or if insulin is more. Now, this is one patient who is already on 8 units of Mixtard, 30-70 before breakfast. You will find that the fasting is 85, which means less than 90, which is normal. Breakfast, post-breakfast is 112, which is less than 120. This is also okay. Lunch is 122, 2 milligram rice, whereas the dinner is 156 milligram. So she is already on 8 units of Mixtard. How can we bring this dinner value low? So this can be done by adding 6 units of regular insulin at dinner. So this will take care of this particular blood sugar. Now, a word about insulin analogs. Insulin analogs are synthetic insulins or recombinant insulins. Now, what happens with rapid-acting insulin, the regular human insulin, is that it has got a delayed peak action. This is the synthetic insulin. You will see the synthetic insulin acts quickly, whereas the peak action here is delayed. It is much less than the synthetic insulin, and the action is prolonged. So because of this, there can be hyperglycemia here, and where the food is already levels, glucose levels have already gone down, it can give rise to hypoglycemia. That is recombinant insulin come in, because the recombinant endogenous of postprandial blood glucose level, better control of glucose levels in the fasting and interdigestive period. There is a lesser risk of hypoglycemia with the recombinant insulin, and the action is very predictable. There is greater flexibility. That means it can be given with meal. The human insulin that we give, that is a regular insulin that we give, has to be given about half an hour before meal. In case the meal is delayed, then there can be a problem. Whereas here, with the meal, it can be taken, or immediately after the meal also it can be taken. And that is the greatest advantage of insulin analogs. Now, the different kinds of insulin analogs that are available are the rapid acting. In rapid acting, we have got the Lispro and the Aspart. Glulicin is not approved. In the long acting, these are called as peakless insulin. The insulin levels don't go very high, but they continue to remain above the baseline for a long period of time, almost 24 hours. This we have Detamir and Glargine. Digludec again is not approved. Where do we give insulin analogs? Women with certain uncertain lifestyle or quantity of meals or the time of meals, very busy person, say she's a air hostess and then, there is no time and she is across the globe, traveling across the globe, then there can be problems. So with food, she can take the insulin. It is not controlled by those in whom the standard insulins are not controlling the blood sugars, or high unpredictable fasting blood sugars or postprandial blood sugars, or risk of hypoglycemia, especially nocturnal. And this happens for those with type 1 diabetes. So in those cases, we can use the synthetic insulins. In most of our women, the regular insulins and the Mixtard insulins that we use suffice. Now, where should the insulin be given? In the first trimester, there is no change in the insulin site or technique. The second trimester, the lateral parts of the abdomen, it can be given. In the third trimester, it can be injected over the abdomen while ensuring the skin fold is properly raised. You must remember this is only a subcutaneous insulin. It is unlikely to go to the uterus, but however, you just raise the skin fold like this and give the injection. Now, what are insulin pens? Because more and more women are now using insulin pens. They provide the convenience and ease of use. The dosaging is very easy. And it has got a 31 gauge needle. So they can hardly feel the pain. And it's a 4 millimeter needle. They overcome some of the barriers for insulin use. Acceptability of insulin has increased after the insulin pens have come. Now, insulin pumps have also made it too. Earlier, it was in the non-pregnant. Now, even the pregnant women have started to use insulin pumps, mostly in women who have a pre-gestational diabetes, type 1 or type 2 diabetes, or brittle diabetes. It checks glucose level in the interstitial fluid. Unlike what many people think, insulin pumps don't check the blood sugar levels. They check the sugar glucose levels in the interstitial fluid, but this mimics the blood glucose. It is helpful in identifying glucose variability, which may not be picked up by point checks with the self-monitoring of blood glucose. So, so many times we think the sugars are under control because all the sugar values that the woman produces on the chart seems to be normal, but many times the sugars go high when we are not checking it. For example, in the night, etc. So how tight should the control be? How strict should we be about controlling the blood sugars? In a non-pregnant person, it is not so important to have a very tight control. But in a pregnant woman, yes, it is very important to the extent that the fetus no longer recognizes the mother as diabetes. This become the first step in the prevention of diabetes and obesity. It doesn't have to work. So, my dear friends, pregnancy is a wonderful opportunity to make a difference to the future of diabetes. And we as obstetricians, the very existence of diabetes depends on the obstetricians. If we are able to make sure that the fetus doesn't recognize the mother as diabetes by giving a very good sugar control, then we have reduced the diabetes in the future population. Nothing is more expensive than a missed opportunity. So we have to make use of this opportunity when a woman comes to us in pregnancy to identify diabetes and to treat it. So let's care for our women. Let's beat the diabetes because it is never too early to prevent diabetes. Thank you very much.
Thank you.
Mukund sir, can you unmute yourself?
Hello everyone. Sorry
Yes,
for
yes.
joining late because of the emergency work. Very nice and informative lecture by Dr. Sushila Rani. And she enumerated the various exercises during pregnancy and diet during pregnancy very well. So thank you very much.
Soni sir, for your comments.
Yes, thank you, Dr. Rani. It was really excellent talk. In particular, the treatment part that you have narrated various insulin, exact doses, type of insulin, when to give, why to give. So it was really very good experience with you. Thank you very much.
Thank you.
Sneha ma'am, over to, for your concluding remarks.
Hello.
Yes, ma'am.
Yeah. Can you hear me?
Yes, you can, ma'am.
Actually, some problem with my audio, but yes, take it. So, in fact, both the speakers I have already talked about their inauguration itself, that they are revered speakers and definitely, the authorities in the field. We are very happy to have you, Dr. Sushila Rani, and of course, Piki. With Madam's vast knowledge and experience in this subject, I'm sure all your doubts regarding the management, not only GDM, but hyperglycemic pregnancy are clarified. I think if there are any questions, we can definitely have it. Otherwise, we can go ahead with the panel discussion.
Prakash sir, you need to unmute yourself. You are muted.
Madam, one question, important question, that when the patient is taking injectable insulin, so she is to be guided in a proper way, because when the patient is already having diabetes in the past, there is a fibrosis of the tissue all around. Sometimes in the given dose, initially the patient is well balanced with the blood sugar level. But if there is some variation in taking the injection at a proper site, there is again a tremendous variation even despite having a controlled dose of the insulin. So what's your opinion regarding this? That some patients, they develop fibrosis in the tissue around the abdomen and the thigh also.
Sir, giving insulin or taking insulin is something that needs tutoring. And the kind of insulins that are now available in the market are very good, and the chances of fibrosis has come down remarkably, I would say.
Okay.
And having said that, they need to change the injection site each time they take. They cannot be taking it in the same site, and that will definitely give rise to fibrosis. Not just insulin, even heparin for that matter, when they are taking it throughout pregnancy, they need to keep changing the site. And a particular advantage on this aspect would be the recombinant insulins.
Right.
Yeah, so but then I wouldn't recommend recombinant insulin for that sake. Most of the time, if it is just a simple GDM, the regular insulin and the mixed-ard insulins that are available can do the job, and just changing the site will make a lot of difference.
Okay, thank you, madam. Thank you.
Thank you, Mukund sir, and thank you, Soni sir, for chairing the session. Thank you, Sushila ma'am, for an elaborate presentation on the management. I'm sure you have made the job of our panelists very easy.
Thank you, Monica.
Yes.
Thank you.
We move forward to the panel discussion.
No, the panel discussion is on hypertensive disorders.
Yes, ma'am.
So I think we need to discuss it at this.
Yes, ma'am. So can we have the slides, please, Shubhankar?
Dr. Sneha, can I take leave, please?
Yeah, sure.
Yes, thank you, ma'am.
Thank you so much.
Thank you
Thanks
for the opportunity.
Thank you very much, ma'am. It was an excellent presentation. Thank you.
Thank you, ma'am.
I was introduced, Monica, so no.
Yeah. So the panel discussion will be moderated by Dr. Sneha Bhuyar, madam, and we please inviting our panelists for the same. The next slide, please. Dr. Bhavesh Nayak, sir, is a consulting practice at Palanpur. Dr. Tapan Gandhi, sir, is a consultant at Akash Hospital and ICU at Disa. He's a consultant gynecologist and laparoscopic surgeon with special interest in high-risk pregnancy. We welcome you, sir. Dr. Vishant Patel, sir, has special interest in advanced laparoscopic surgeries and infertility. He had secured the first rank in ICOG laparoscopy exam courses. He has received the Young Hysteroscopic Surgeon Award and the Top in Laparoscopy Suturing Award with the Best Paper Presentation Awards at 2 international conferences. We welcome you, sir. Our next panelist, Dr. Priyanshu Patel, sir, works at Sparsh Women Hospital at Mehsana. He's a laparoscopic surgeon and a sonologist. He has done his post-graduation from D.Y. Patil Medical College, Mumbai. And currently, he is the secretary of the Mehsana OBGYN Society, and he has been the ex-secretary of IMA Mehsana. We welcome you, sir. Dr. Zalak Shah works at Rachana Women's Hospital at Patan. She is interested in infertility, high-risk obstetrics, and improving women's health through preventive and postpartum care. She is currently the secretary of Patan OBGYN Society. We welcome you, ma'am. Dr. Nisargi Patel is a board-certified infertility and laparoscopic surgeon with a diploma in aesthetic and functional gynecology. She is a member of ISP MP, a consultant at Gayatri Maternity Home at Patan. She has been working as an ex-assistant professor at WIMS Kerala. We welcome you, ma'am. Dr. Narbat Chaudhary, sir, is a consultant gynecologist and laparoscopic surgeon at Navjeevan Hospital, Tharat. His interests include fetal medicine, high-risk pregnancy, and pelvic floor surgery. We welcome you, sir. Dr. Sandeep Patel, sir, has been practicing since last 15 years at Ashish Hospital at Idar. He has been the past president of HOGSO, the past president of Idar IMA branch, and he has been the organizing vice chairperson at SOGOG 46. His special interests include laparoscopy and fetal medicine. We welcome you, sir. Over to you, ma'am, for the panel discussion.
Yes. So very good evening to one and all. Once again, thank you, Monica, for that kind introduction of all the panelists. I would just quickly share my PPT, and without much ado, we would start with the panel discussion. I have already talked to you that we have selected a very routine scenario which you face in your day-to-day practice. So Dr. Tapan Gandhi, Dr. Vishang Patel, Dr. Priyanshu, Dr. Bhavesh Nayak, Dr. Jalaksha, and Dr. Naisargi. Do we have all of them here? Can we just put on your video, please? Naisargi? Jalak? Yeah, hi. And please try to unmute yourself. Can I say hi to all of you?
Hello, ma'am. Good evening,
Yeah,
ma'am.
hello. Good
Hello,
evening.
ma'am.
Good evening,
Good
dear.
evening.
Yes, I have a young brigade, and I think I can see majority of them are laparoscopic surgeon, but I'm sure you all are running your obstetric hospitals very nicely. So I'm happy to have all of you here. And without much ado, I would start with the panel discussion. So friends, we have heard at the beginning of the program itself that hypertension, hemorrhage, and sepsis, these are the three major killers of our women. And in spite of having so many predictive factors, including the maternal characteristics and also the mean arterial pressure and the rollover test, and you have the various advanced biochemical and biophysical tests. Like biophysical test, you have the uterine artery pulsatility index, right, at 11 to 13 weeks. You have the various biochemical tests like PLGF and SFLT. In spite of all this, we do not have reduction in the incidence of HDP, that is hypertensive disorders of pregnancy, and the morbidity and mortality associated with it. We do have the protective medications like low dose aspirin and high dose calcium, but still the incidence is not getting reduced. You heard that recently whatever 2-3 deaths happened, that was related to hypertensive disorders, and definitely, it's a matter of concern. So, Dr. Professor Mohammad Fatala has expressed that women are dying not because of the disease we cannot treat, but because the societies have yet to make the decision that their lives are worth saving. So, friends, we need to really introspect and take, we have to take this challenge, and we have to take every patient that visits our OPD very seriously. Hypertensive disorders of pregnancy is a multi-system disorder, and that is why you need to be very cautious. So let us start with Dr. Tapan Gandhi. So Dr. Tapan, we have this young lady, 22-year-old, primi gravida. She belongs to a low socioeconomic status, and she has no known medical disorder, prior to the pregnancy. She is booked with you regularly, coming to antenatal checkup. And at 32 weeks, she presents to you in OPD just for routine checkup. When you take her blood pressure is 150/90. So let me ask you, how would you go ahead with the management of this patient? So my question to you is whether you will call her as hypertensive, that is one, whether you will do some investigations, that is second question, whether you will start with the antihypertensive or hospitalized. So, Dr. Tapan, please start
Yes,
whether we can call this patient as hypertensive disorder of pregnancy. Yes.
as ma'am, I will first ask her for the history uh, because as the I will or examination part, I will take first history whether she has any history of PIH in previous pregnancy or not.
She's primary gravida, Dr. Tapan.
Primary gravida, and I will age is 32 years, 22
22.
years. Okay, okay.
She's a young primary gravida.
Young
Okay.
primary gravida.
Mm-hmm.
So, as there is BP is 140/90, so I will take second reading again after half an hour,
Okay.
and I will see what is her BP.
Yeah,
And
why do
so,
you want to take her blood pressure again, and what are the ideal conditions in which you want to take her blood pressure?
madam, as the PI, it shows that the blood pressure is high. So in many condition, what happened that patient
has just come after walking, so it may show high BP. So I will relax her for half an hour, 1 hour,
Right.
and I will take again. And if she's
Okay.
again the second reading is high, then I will go for investigation.
Okay. What
And
investigations you want to go for?
ma'am, first of all, I will examine general investigation.
Yeah.
Whether she's febrile or not, or what is the respiratory rate, and
Clinical
whether she has
examination. Clinical examination, you mean?
clinical examination. First of all, I
Okay.
will go.
Okay.
And then I will examine per abdomen whether there is any uterine contraction or not, or what is the fetal position,
Okay.
and what is uterine tone,
Okay. ठीक है
and
ना?
is there
My
any
question
edema
to
or
you
not.
is whether you have taken a blood pressure initially, so you felt that she must be, she must be rushing to your clinic, number लग गया कि नहीं वगैरह, doctor होंगे कि नहीं. So now you want to relax her for 10-15 minutes at the most, okay? So here the ideal condition should be that she should be in a physical and mental relaxation, state of physical and mental relaxation. So your first message should be, we cannot label her as hypertensive just with a single reading.
Single
Okay.
reading. Yes, madam. Yeah. Yes,
Is that
clear.
clear? Yes. Yes. So that is the message from your side, that yes. Other panelists, can we have the inputs from all of you? Dr. Jhalak. Dr. Jhalak. Do we have the panelists here? Please put on your videos. Please put on your videos.
Yes, ma'am.
Dr.
Yes,
Jhalak.
I'm here.
Yes. Yes, Jhalak.
Yeah.
So should we label this as hypertension?
Hello.
Okay.
Am I
Yes,
audible,
please.
ma'am?
No, ma'am.
Yeah, yes, ma'am. If the girl is young and she is a primary with newly detected hypertension, so after 2 readings or so, if the BP continues to be 140/90 according to our FOXY or ICOG guidelines, we can start with labetalol at least.
Yeah, but then you label her as a hypertensive only if you take her blood pressure again after 4 hours, not before
Yes,
that.
ma'am.
Okay.
Yes, ma'am.
Yes. And then
And
how should you take the blood pressure? Which arm, whether sitting or lying down? Tell me.
Yeah, ma'am. It can be taken in sitting or lying down position, but the BP instrument should be at heart level.
Okay.
And better if she has been given half an hour or so rest. But after rest, many times the BP comes down, but it can again shoot up if it's really PIH.
Yes, yes. Go ahead. So
So
what is the
that
ideal condition?
yeah, ideal condition is maybe sitting with the doctor and the BP instrument at heart level.
Okay.
And the cuff should not be too tight or too
Yes,
loose.
appropriate
It should
size
cover
cuff.
2/3 of the arm and like that. Yeah.
And ma'am, her feet should be on the land, and she should not drink coffee prior to taken BP or 1 hour prior BP. We have to ask coffee or tea history also, whether she had
Correct.
taken tea or coffee 1 hour prior or not.
Yes, or even any other drugs, whether she has consumed, maybe even eye drops, that also can make the difference.
Yes,
okay. So that is how it is. Okay. So she should be physically and mentally relaxed. She should sit comfortably, what you meant to say, that her feet should be touching the ground, and the
She should have slept.
your
The sleep should be
should
good.
be good,
Yeah.
comfortable, and the size of the cup should be appropriate. Okay. So now even after 4 hours, your patient's blood pressure is 140/90. That is how we can label her as hypertensive. Now you tell me what investigations, whether it is non-severe or severe, how do you decide that? What history you want to ask? Somebody was talking, Dr. Tapan was talking about history.
Yeah.
So what are the history points, alarming symptoms?
Madam, then I will like to go for routine investigation of this patient, particularly urine protein. If it is more than 300 ng per 24, that will be significant. That we can label her as a PIS.
Okay.
Then I will like to go for CBC. I will like to see thrombocytopenia, then liver function test, renal function test.
Good, very good. And what about the clinical history? You said the alarming symptoms. What you want to ask her?
Typically, is there any headache or not? Patient and pedal edema.
epigastric pain,
Pedal edema is
Epigastric
not
pain.
a
vomiting,
severe feature. Pedal edema is not a severe feature. It is just a feature to diagnose. Okay.
epigastric pain,
Any
blurring of
any
vision.
visual disturbance?
Visual disturbances.
Yes.
So
Perfect.
blurring of vision, then
Visual.
vomiting.
Then in urine examination, if there is proteinuria.
Yes.
It's
And of course, if she has, symptom or a history of less urine output, that is oliguria.
Oliguria.
So here I have displayed for you that severe headaches, visual disturbance, upper abdominal pain, convulsions, maybe pulmonary edema, the other signs like proteinuria, oliguria, and elevated liver enzymes or impaired renal function test. So all these will, indicate that it is a severe condition. Okay. So even don't go by blood pressure. Even if she has a blood pressure 140/90, if she has severity features like these alarming symptoms or signs, or if she has impaired laboratory parameters, then even with this blood pressure, she can be severe hypertension. Okay. Okay. So now what happened, well, you have labeled her as hypertensive. Now, should we start her on antihypertensives, and which? Dr. Visham, we come to you. And Dr. Bhavesh also. Yes.
Uh, Ma'am, as this is the first time diagnosed gestational hypertension, and we will go with the laboratory parameters, the
Yeah.
urine albumin levels. We should start antihypertensive when the diastolic BP crosses more than 90 millimeter of mercury, as per the FOXI guidelines and
More
ICOG
than
guidelines.
90. Correct. You're right.
Yes, that's okay.
Okay.
And
So
this,
these are the guidelines saying, previously by NICE guidelines were there in 2010. It is to tell you that start antihypertensive only when the BP goes 150 and 100, 150/100. Okay, but I'm sure you must have even witnessed that some of the patient converts on 140/90. Okay, and that's a reason CICOG and World Justice has come up with these guidelines that even if the patient has 140/90 millimeter of mercury, that is a cutoff to start antihypertensives. Okay. So now, Dr. Bhavesh, you tell me, suppose this patient has got this 140/90. So what antihypertensive you want to start for her?
Nowadays, the choice of antihypertensive is labetalol is considered. First, we admit the patient, evaluate to diagnose and stamp as a proper pregnancy-induced hypertension.
Yes.
Rule out the other
Why
investigation.
labetalol? And what are the other drugs?
Now the labetalol is a first choice of the drug because it is sudden onset of action. Previously, in our era, we used the alpha methyl dopa.
Right.
But onset of action is probably starting after 48
Yeah, so
hours.
I would ask you a question one by one. Why you want to start labetalol? What are the advantages?
Advantage is it is a safe. It is a both alpha and beta antagonist, and it is also not associated with tachycardia and not central acting.
Okay.
And apart from the alpha methyl dopa,
Yes.
and
Yes.
it is safe to both fetus and mother.
Yes. Yes. So it
Even
maintains the blood pressure level, and also, yes, Dr. Nisargi, you want to?
it lowers the BP by reducing systemic vascular resistance and
Right.
cardiac output. So without reflux tachycardia, that's why it's used for both emergency and maintenance setting also.
Perfect.
And no major impact on uteroplacental insufficiency, ma'am.
Perfect.
Perfusion.
It doesn't interfere with the uteroplacental perfusion. So there is no fetal growth restriction if you use labetalol. Okay. And if you have severe hypertension, you can switch over to injectable. Correct. So that is the advantage for labetalol. Now you also have what is called as tablet nifedipine retard and alpha methyl dopa. Now I asked Dr. Jalak, Doctor, why not to use tablet nifedipine retard? The tablet, not the orange color capsule. It is also a slow acting drug. So when do you use that?
Yes, ma'am. Nifedipine retard is a calcium channel blocker drug. So what does it do is it does vasodilatation, thereby decreasing the blood pressure, which in turn causes tachycardia. And because of tachycardia, many people have palpitation, and headache is very common due to dilatation of vessels. So it's not a first drug of choice, but if labetalol or beta blockers cannot control the BP, it helps. right? And in some cases where vasodilatation and bronchial action of calcium channel blocking is required, like in asthma, it may be beneficial over labetalol too.
Right. So if
Right.
you have yes, anybody else want to add something? Okay, so if you have some contraindications like asthma or cardiac blockade, maybe severe bradycardia, then you cannot use labetalol, and that is the situation where you have to choose tablet nifedipine. Okay. Now we have talked about why labetalol, why not alpha dopa? Dr. Tapan, once again from you.
Yeah. Madam, actually, labetalol is better tolerated and fast-acting drug compared to alpha. And it helps in
Why
cervical
not alpha
rightening
methyl
also. And thing is cost-effective also. And there are a lot of side effects of alpha methyl dopa, particularly epigastric pain and nausea, vomiting. So better to give first-line drug as a labetalol.
I don't agree with you. Anybody else want to?
Postpartum depression.
Postpartum depression.
Yes. So
Yeah,
if I tell
postpartum
you first reason, you all should say that it is not available. Okay.
Okay.
This drug is not available. That is the most important reason for not using. Because if you ask our generation, 35 years ago, we have used this drug day in and day out because that was the only drug available and that was very safe and cost effective. Okay. Let me tell you. But only disadvantage was it was having a very long onset of action. That is 24 hours.
Yeah.
पहले दिन जब देते थे तो इफेक्ट ही नहीं आता था 2 TDS 2 QID तक देते थे सेकंड डे सडन हाइपोटेंशन होता था okay so patient tries to get up and she is to fall so postural hypotension होता था patient yes so mainly it is the postpartum depression postpartum blues and severe headaches okay and then of course the minor problems what we are talking about but alpha methyl dopa was otherwise a good drug but it is not available okay it also used to not interfere with the pitoplacental circulation and there was no FGR okay so any opinion about rest strict bed rest and salt restriction Dr. Visham?
Ma'am, as such, there is no benefit from salt restriction once the hypertension has been diagnosed. Bed rest or sedative is also not that much useful in preventing severe hypertension.
Yes. In fact, I would say that you should always talk about there is absolutely no need for strict bed rest. In fact, it can be detrimental to the patient's health because strict bed rest will lead to thromboembolic phenomenon, right? And of course, salt restriction, this patient already has hyponatremia. If you reduce the sodium intake, she will go into hyponatremia. That's a very reason. It's only adequate salt intake, no extra or no table salt. Okay. So friends, challenges are what makes life interesting and overcoming them what makes life meaningful. So what this, this obstetrician was from old school of thought. So she thought it is 140/90 mild hypertension. She just prescribed her routine medication and sent her home and asked her to come back only when if she has any problem or maybe next visit as a routine. Suddenly, 5 days later, this patient was brought to the hospital with severe headache, nausea, upper abdominal pain. And when you examine, the BP was 170, 110, reflexes brisk, and there was epigastric tenderness. Can you tell me, Dr. Priyanshu, what is this complication that has happened now and how will you tackle this?
First of all, if systolic BP is greater than 170 and diastolic is 110, then I would diagnose the patient is in hypertensive crisis and investigate first. Fetal Doppler sonography. If fetal is compromised and the fetus is going to IUGR, then take a plan to.
How will you manage crisis? How will you decide whether you want to take her for seizure immediately or you want to give her
all investigation.
Okay.
All investigation patient CBC. If any thrombocytopenia, urine examination is there is any proteinuria, total albumin is
done
less.
already. That we have done. But when you have severe hypertension, it is called a severe hypertensive crisis. Okay.
Yes,
So you have to manage this patient, and you have to decide whether you want to control this blood pressure and continue the pregnancy, or you have to control hypertension and immediately take her for cesarean section. That you have to decide. So how do you decide that? Yes. It is decided by the investigation, which tells you whether she has landed up into end organ failure. Okay.
yes,
That means if you have impaired liver function test, if you have impaired renal function test, then she has landed up into end organ failure. So that is called as hypertensive emergency.
yes, ma'am.
So because if you have end organ failure, you have to control the blood pressure as soon as possible and deliver her.
Yes,
Okay.
yes,
But if you don't have end organ damage, the investigations are not so much impaired, then definitely you can control her blood pressure slowly over 24 hours, stabilize the patient, and then you can continue her pregnancy. That is what we are doing, correct? Okay.
yes, ma'am.
So let us go ahead. See, you can see here emergency, and you have to remember E for E. Emergency means end organ damage. Okay. So if you have end organ damage, control as soon as possible and deliver. If you don't have end organ damage, control over 24 hours slowly and take this pregnancy ahead. Okay.
Yes,
Why do
ma'am.
you want to manage this, severe hypertension aggressively, Dr. Vishal? Otherwise, what will happen?
Uh, we definitely want to prevent the end organ damage on the maternal side, and
Yes.
we definitely want to prevent the fetal complications.
Right.
So the patient has landed in emergency with 170, 110 BP. So we will admit her. This is a pre-eclampsia.
No, I'm just asking you the question. You will manage her. I'm just asking why you want to bring down the blood pressure so fast, because otherwise what will happen to her? What complications she can land up into? That is what I'm trying to ask.
There are many complications like stroke, the cardiac failure, pulmonary edema,
Yes.
eclampsia.
Naturally, eclampsia is the first complication that you can think of, and then of course pulmonary edema, myocardial infarctions, and even hepatic rupture has been, observed in some cases. So, what are the drugs available for this severe hypertension now? Which one you prefer, Dr. Vish? Anybody?
IV
Injectable
labetalol.
labetalol.
Yes,
IV
Dr.
labetalol.
Bhavesh. Yes.
IV labetalol is a choice of prefer, but in
Any
case
other
of
drug? Any other?
we should use a prophylactic Maxalf.
I heard sublingual definitely. I heard sublingual definitely. It's a crime. Okay. First thing, at least from this program, we have to learn and take a single message home that absolutely no for sublingual nifedipine. Okay. Yeah, there is a image also I will show you in in some time, but that is called as oral nifedipine. Okay. Capsule nifedipine, orange color capsule, 10 milligram, and of course IV labetalol. These are the two main drugs, and then you have hydralazine, etc. We come to that. Okay. This is the list of investigations. This is the list of medications: intravenous labetalol, oral nifedipine. Mind well, oral nifedipine capsule, and intravenous hydralazine, NTG infusion, nitroglycerin, and sodium nitroprusside. Now we come to labetalol. How do you give intravenous labetalol? I think Dr. Nessergi, we start from you now, this discussion. Nessergi, Dr. Nessergi, Dr. Jhalak, we want to hear from you. How do you give labetalol? Have you used, do you use in your practice or in the hospital? Who wants to talk about this?
Yes, ma'am.
Yeah, please.
IV labetalol, the ampule is 10 milligram. So we can give the ampule 10 mg IV, and then can
Not
again
10,
be repeated
it is
after
20
15.
milligram.
Yes.
20 to 10 mg, we can give 1 ml of it, and then repeat it after 20 after 20 minutes again till maximum dose of
10 minutes. You have to wait for 10 minutes only, because you have to bring down the blood pressure quite fast. Okay. If it is emergency, then you have to bring it down as soon as possible. At least from 170, 110, you have to get it to 160, 100. Okay. So
Yes,
if
ma'am. So it
at all
can
you
be
don't,
repeated till approximately 200 to 300 mg.
330.
so you
No,
started with
repeat.
20 mg. Okay. Then how do you
Yes.
give it? How do you give it?
It can be repeated at least 8 times.
Diluted.
Yes.
We should
Yes.
dilute in 10 cc syringe and
Okay.
give very slowly over
Mm-hmm.
2 to 3 minutes.
Okay.
Otherwise, also we can start infusion.
Okay. Suppose you give 20 mg as a bolus initially, wait for 10 minutes, there is no desired effect, no fall in blood pressure. Then what do you do? Give the double dose, that is 40 milligram. It's very
40.
simple. It's, you have to just remember, give double dose. So if no response for 20 milligram, give double dose 40 milligram. Wait for another 10 minutes. If no response, give 80 milligram.
80.
Okay. And as you have rightly said, maximum you can give up to 300 milligram. Okay. So, but then if after 80 milligram you don't have the response, definitely you have to add with the other antihypertensive. How do you give oral nifedipine? So intravenous labetalol, the action is very fast, you know, so that is why it takes only 10 minutes for the peak action. Okay. How does nifedipine act and how much is the dosage? What are you using for severe hypertension? Please let me know.
But ma'am, if I have given nifedipine on admission, finding such patient, and then
On
IV
admission
labetalol is
means when
also
you have
given.
severe hypertension. If you have severe hypertension, then only you will be giving, no, nifedipine
Yeah,
capsule.
yeah, that's what I'm saying. If I am giving,
Nifedipine.
Yes,
if I
Nifedipine
am giving,
in
20 mg.
nifedipine 10 milligram. It is available as 10 milligram orange
Mom,
capsule.
initial dose, if it's severe hypertension, initial dose is 30 to 60 milligram, followed by 20 milligram BD, and maximum we can give in a day 120 milligram orally.
Whenever we are using oral capsule nifedipine, the dose has to start from 10 milligram only, because you don't know whether this patient is how
how much
sensitive is
hypertension?
she and how much hypertension she will end up into. So start with 10 milligram. Okay, there is no question of starting with the higher dosage, because you have the fetus inside. If you have certain hypertension, you will lose the baby. Okay, always, whatever may be the, no hurry. There's no question of giving sublingual, no question of giving even 20 milligram. Start with 10 milligram, because the onset of action is very fast. Within 5 minutes, you will find the drop in blood pressure. And the peak action is 30 minutes. Duration is 6 hours. And that is why start with 10 milligram. If you don't have the effect within 5 minutes, and if you don't have the maximum effect within half an hour, then of course you give another 10 10 milligram capsule. Okay, that is how you have to titrate with the blood pressure. Correct?
Yes, ma'am.
Yeah. So see, this is the policy that you should not bring down the blood pressure very fast. 170 110 से एकदम 140 90 नहीं लाना है. It is only 25 to 30% reduction. So 170 110 से 160 100 लाना है पहले, फिर slowly, and then you try to maintain on 140 90. That is what is the policy. So we have discussed about this labetalol, nifedipine, hydralazine, and your patient has landed up into hypertensive crisis. In spite of that, never ever give sublingual capsule nifedipines. Never. Even if I remember myself as postgraduate students, some of the residents, even maybe we have used it that time. We have, we used to prick the capsule, because these are the teaching by the seniors. We used to prick
Yes,
the
ma'am.
capsule and pour few drops, maybe not the whole capsule, but because we were
We
happy.
have also done that.
Yeah, but there have been many patients we have lost. Maybe few patients collapse, and you have to manage it very aggressively. So don't even think of giving sublingual nifedipine. Okay, that's the most important message.
Oral.
Yes, oral capsule nifedipine. You do have one more nicardipine, one more antihypertensive, but then it is not used, so I will not discuss it. Just to know that it is also a calcium channel blocker from the second generation dihydropyridine derivative. It is 100 times more soluble than nifedipine, and that is why it is available as injectable form also. So intensivists are using this drug, but we have never tried. So I also do not have any experience on this. And you have the esmolol, which is also very short acting antihypertensive. For obstetrics, we do not want drugs which are, giving you sudden hypotension. That is why we don't use this drug. Okay. So Dr. Salak, suppose now you have managed this patient's hypertensive crisis very well. You have managed her on maybe initially by IV labetalol, and then once she is controlled, now you are stabilizing her on oral tablet labetalol. Now you want to take this pregnancy to 34 weeks at least. But suddenly she can develop into some complications. Suddenly she can develop some complications. So what are they for which you may have to terminate the pregnancy or induce her? Yes.
Yes, ma'am. They can be development of convergence, eclampsia, visual disturbance with increase eyeball pressure. Then abruption can help syndrome,
Yes.
acute renal failure.
Yes.
Then
So you have certain maternal complication. What you?
Yeah, these are maternal, and some fetal complication like absent and diastolic flow or reversal even of
Correct.
fetal cerebral. So these are the things which. So we have to give corticosteroids should be kept on giving from 28 weeks every month.
Correct. Yeah,
These
Shubhankar,
things can.
Yeah. Yeah, so already you have discussed that these are the complications where maternal side you may have to terminate or induce the pregnancy, induce the labor, and these are the fetal complications: severe FGR, absent or reversal of end diastolic flow, severe oligohydramnios maybe, and also the fetal death. If the fetus is dead already inside, then what is the point going ahead? Correct. So we come to Dr. Nisargi now. Nisargi.
Ma'am, as so many regimen are there for max sulfate, but we are mainly using Pitchard's regimen and Juspan regimen. So Pitchard's regimen, it's like where ICU availability is not there, that we can use Pitchard regimen. Loading dose is 14 gram. So in that 4 gram of 20% of max cells, we are giving in 100 ml NS over 3 to 5 minutes slowly, and 5 gram
How do you
each
prepare
buttock.
that? How do you prepare? You are using it routinely.
Ma'am, yes, ma'am. So 4 gram means 4 ampule we are taking, and 12 ml of NS we are taking. We'll
Yes.
dilute and slowly
That
we are
becomes
giving
8
over 3
ml
to
and 12 ml. That is 20 ml total.
12 ml. Yes,
Correct.
yes, ma'am. And per 5 gram of each buttock IM we are giving of 50% of MgSO4. That is loading dose for PCR treatment. And every 4 hours we are giving alternate buttock 5 gram till the 24 hours of delivery or last dose of 24 hours. And Juspan regimen is
Yeah,
used for
I will just
ICU setup.
interrupt you here. You have said the regimen
Yes,
very
ma'am.
correctly. Meanwhile, you have to monitor certain parameters.
Yes, ma'am.
What are they and how frequently?
Ma'am, will for loading dose, no need for monitoring. But after that, we have to monitor urine output, respiratory rate, pulse,
During loading
SpO2.
dose, why no monitoring? In fact, I would say you have to attach the NIBP and everything. All the
Yes, ma'am.
para you will give. Okay. So
Yes, ma'am.
even while giving, you have to give it very slowly, for
Slowly.
10 to 20 minutes.
Minutes.
Yes. Otherwise,
And
patient feels so warm and she vomits out.
she'll feel burning sensation
Yes.
also.
And sometimes even the respiration, she may have problems. Okay. So breathing difficulties because this is
And
a respiratory depressant drug. Okay.
And
Now,
starting monitoring, ma'am, every half an hour to 1 hour, we have to monitor pulse, BP, SpO2, respiratory rate, deep tendon reflex, and urine output monitoring.
perfect.
Then
How should be what should be the respiratory rate and what should be the urine output minimum?
Ma'am, urine output should be 30 ml per hour or 100 ml per 4 hour. And the respiratory rate should be 14 to 18 per cycle per minute.
Okay, so I just ask you one question. You have described the regime very correctly. What is prophylactic maxil?
prophylactic myself, ma'am, we can give 4 gram in 100 ml of NS, IV slowly. If we are having only BP or patient is telling some symptoms like it's superimposed symptoms of preeclampsia.
Okay. What I want to tell you is, it's only the word prophylactic means to prevent convulsions, to prevent eclampsia. But the dosage and the schedule remains the same. You know, some people confuse with the therapeutic and prophylactic dosage. They feel that prophylactic means you give only one dose and you forget, or maybe you give half of dosage. No. Okay. Whether it is prophylactic or whether it is therapeutic, once you start with the Peters Maxwell regime, it should be
24 hours.
As you said, 24 hours. Okay, so this is Pritchard's you discussed already. Can somebody talk about Zussman's regime? Dr. Bhavesh?
Yes, madam. Zussman regime is initially the loading dose 4 gram, then 1 gram per hour. That is a 500 ml D5% bottle. You should add the 5 gram Maxel and per hour 100 ml per hour.
Yeah.
Better to give with the infusion syringe or if you monitor with the drip up to the 24 hour. It helps in also it is the same
But
dose.
here, yeah, let me clarify. But you know, because for our patient of PIH or a hypertensive disorder, she already has fluid overload. If you are giving 500 ml of fluid and you are giving only 5 grams, so 5 hours, okay, it will be, and you are giving it for 24 hours, correct?
Yes, madam.
So you are adding at least 5 pints of fluids to her when she already is in fluid overload, so she can go into pulmonary edema. So to cover this, nowadays we have the concentrated solution of magnesium sulfate, right?
Yes, ma'am.
You
Yes.
have only 100 ml IV mag, that is the preparation's name, but not to use 500 ml, but use 100 ml, which has all 5 gram of magnesium sulfate. Okay. Okay. Did you get it? Yeah. So Blisson Pharma and maybe some other pharma, but we just know that there is, to have the fluid restriction, we should use concentrated solution. So naturally you have to give it very slowly. It has got 4
1 gram per hour.
Yeah, it is 4 gram. It has in 100, so 25 ml per hour. So actually you have to have the micro infusion set, right?
Dose is also same for cranioprotection of the baby. If it is a pregnancy between 28 to 30
Neuroprotection.
neuroprotection.
Less than 33 weeks.
28 to 32 weeks if the
32
baby is.
weeks, 6 days to be precise. Okay. So suppose you have already given her prophylactic maxes and your patient convulses immediately. Dr. Tapan. Do we have Dr. Tapan?
Yes, ma'am. Yes.
Yes. So suppose you, Dr. Tapan, we have given prophylactic magnesium sulfate. We have just given, and suddenly, you know, your patient is convulsing. So would you like to give her again, or how?
No. No, ma'am. There is no role of giving again. And we have to assess the patient.
Because whatever drug you have given, that has not started acting as it. It will take at least 10-15 minutes to, you know, show its effect. Suppose your patient is convulsed after 15 to 20 minutes. Now what will you do?
First, we have to terminate the pregnancy, madam.
No. No.
We should give other anti-convulsant.
Convulsing. You have given her...
we can give diazepam.
No,
but we have to monitor the respiration.
Okay. Anybody else wants to add?
We can repeat the 2 gram IV.
IV. Yes. So that is what is the answer, that if you have already given loading dose, and even after 15-20 minutes of the time, if your patient is convulsing, then maybe you may have to repeat 2 grams. Okay, that too again slowly diluted over 10 minutes with all the monitoring. Okay, but suppose if your patient is repeatedly convulsing even after this, now you tell me, Dr. Bhavesh, you can continue.
This is labeled as a statal eclampticus.
Correct. Then what will you do?
Termination of pregnancy under general anesthesia.
General anesthesia.
So is that the only thing, status eclampticus, or there is something else?
There could be a CNS cause also, madam.
CNS.
That is what. If you have given full loading dose In spite of that, if your patient is convulsing repeatedly, that means there must be, because of this severe hypertension, she may have had some rupture of some vessel, cerebral.
Aneurysm rupture also.
Yes, some neurological cause you have to think
There
of.
may be encephalopathy.
Yes, and then you have to call in the neurologist into picture. Okay, so
Right.
what parameters already Dr. Nesargi has talked about. Suppose you are monitoring this patient, the reflexes are absent. When you want to give the repeat dose, the reflexes are absent. Then what you should do? Whether you should give that dose of Maxel or how?
Hold the dose.
Hold that particular dose. Okay.
No. Yes.
Hold
Yes, ma'am.
that particular dose.
Dose.
Stop
Monitor the urine output.
Yes, monitor again everything. And if
If
after
there
4
is
hours,
respiratory depression, there may be given to antidote calcium
yes.
gluconate.
So what is the antidote and how do you give it?
Calcium gluconate
How much?
IV diluted.
Yes.
It's a rule of 10. It's rule of 10, 10, 10 plus calcium 10 mg calcium gluconate in 10 ml NS over 10 minutes. It's
Correct.
rule of 10.
Yes, yes. But here you must have the ECG monitor. Okay.
Yes, ma'am.
Okay.
For respiratory.
So, yes, perfect. So as we already talked about this, if you have severe hypertension before 26 weeks, then you cannot risk the mother's life. Okay. You have to just stabilize the patient and terminate. Now that you have managed this patient very well, you have brought her up to you are trying to bring her up to 34 weeks with expectant management. But if at all you have some certain problems, then you may have to go for induction. Otherwise, you take her to 34 weeks and you deliver. If you have 34 weeks pregnancy and if you have very severe hypertension, you have to just stabilize and deliver her. Correct? So, Dr. Vishang, how will you optimize the neonatal outcome in this? Because she is now landing up into preterm delivery.
Yes, ma'am. The steroid coverage, the max help is already given. That
Yes.
will also act as a neuroprotection for
Yes.
the fetus.
Yes.
And we will try to deliver her by LACS as soon as possible.
Correct. So you are right. So you have already prepared this baby by giving antenatal steroids for lung maturity and magnesium sulfate for neuroprotection. So because you don't have any alternative now, because to save the mother's life, you have to terminate the pregnancy. If she is not, of course, you cannot risk her life by giving her the labor, if she is not having, that will again depend upon, if the fetus is not much compromised, you may look for whether she's, her biceps is favorable or no. And you may have to decide whether you want to post her for cesarean section or you want to try and deliver her vaginally. Now, this patient is already, the mother's condition is unstable, the fetal condition is unstable. So here we don't have the choice but to go for cesarean section. Okay. So what will be the anesthesia of choice?
Epidural.
Yes. So best way is to, best way is to leave it to the anesthetist. Okay. You decide whatever. But if at all the coagulation profile, everything is normal, go for regional anesthesia, preferably epidural. But suppose your anesthetist is very adamant on general anesthesia. So what are the problems with general anesthesia?
Baby compromise, chances of baby compromise.
Uterine relaxation.
Yes, uterine relaxation with atonic. Yeah, atonic PPH is the chances are very high. Okay. So this patient, as I said, that you have stabilized her, but in spite of having so many antihypertensive drugs and you are stabilizing her, but in between she gets unstable and suddenly she starts getting very severe pain in upper abdomen, headache. And when you examine, you find this tachycardia and BP is 170, 110, reflexes are brisk. Per abdominally, her uterus is tender, tense, and fetal heart is 110 only. Fetal parts are not palpable. Well, I mean, it is a tense uterus, and there is a bleeding, brownish color. Yes, so this is abruptio. So, what investigations you want to do for confirmation?
USG.
But yeah.
100%.
Ultrasonography we have to do for abdomen, pelvis to rule out retroplacental clots also, and liver hemorrhage or any other hemorrhage.
But USG may not show immediately.
Yes. You can have some RP clot if at all, if it is totally a concealed, because it is only spotting or little bleeding. So you can have a retroplacental clot. USG may not show it immediately, that is one point. But yes, because if the uterus is tense and tender, that means there is a significant concealed hemorrhage. Okay. And the fetal heart is also going down. So definitely she's having a significant RP clot. Now, when you investigate her coagulation profile, platelet count is only 50,000. Bleeding clotting time is okay, but she has FTP, fibrinogen degeneration products present, and fibrinogen, it should be 400. Now it is only 150. Now, what is this condition? How do you treat it?
DIC.
Yes, your patient is, yeah. Yes.
It's DIC.
Yeah, your patient is going into DIC, but then how do you judge what is the severity of DIC? How do you score? What is
Fibrinogen level, D dimer and fibrinogen level, and
platelet count.
Yes.
DIC score.
Right. So you have this DIC score, which takes into consideration platelet count, the fibrinogen degradation product, that is D dimer, and prothrombin time, and fibrinogen. Okay. So if you have a score of more than, if you have a score of more than 5, then it is severe. If it is less than 5, then it is non-severe, but it is DIC. Okay, early DIC. Okay. So for this patient, the heartbeats were confirmed. But in spite of controlling the hypertension, in spite of stabilizing the blood pressure, she persistently had severe headache. Okay. So because of this emergency, abruptioplacenty, she was to be taken for cesarean section. But somebody thought of doing MRI because she was having very severe throbbing pain. So yeah, so bilateral parieto-occipital lobe were showing subcortical edema. There was low density areas of white matter over posterior lobe. So what is your diagnosis? How do you treat it?
Posterior reversible encephalopathy syndrome.
Okay, so how do you treat it?
Fluid, IV fluid and rest. It is reversible.
Mannitol is
Should we give fluid or should we not give?
anticoagulant.
It's edema all over.
But we should shift the patient to the ICU. The IV mannitol should be started. The steroid should be started. The press is usually reversible, but should take the consent of the family. Okay. And the depends on the clinical features.
Yeah. Do we have
should
Dr.
control the
Priyanshu?
hypertension, control.
Do we have Dr. Priyanshu?
Yes, ma'am.
Yeah. So, how would you explain to the patient and relatives that, why this happened? The patient will blame you that she was under your care in spite of all this. Why she developed this? So what stand you will take? Then they will say that we want to shift the patient. So what is your, what is your opinion about this condition? What do you know whether it is, reversible or how?
Reversible.
Yeah. Let me ask him what he will counsel the patient and relatives. Because she ends up into cortical blindness, right?
Yeah.
Yeah. So how do you tell them?
It's a complication due to pregnancy, PIS. It's a hypertensive crisis.
Okay.
And patient require ICU management.
Okay.
And mostly it's a reversible process, so it's take a time for 7 to 10 days.
Right.
And we have to control.
What medication you want to give for this?
Mostly mannitol.
Yes, mannitol and steroids. Dexamethasone.
Yes, mannitol, steroids.
Right.
We can give Levipil also.
Yes. Yeah, because she lands up into convulsions. So definitely you have to stabilize her, give her anticonvulsant, mannitol, immediate delivery. Okay. So this patient was actually taken for cesarean section, and she had a baby which is, and she recovered after 7 days. Okay. So you have to have the knowledge that this is a self-limiting condition and the reversal rate is very high. The prognosis is very good for this condition, even though it is severe, but we don't have to take it very lightly. We have to rule out other intracranial and neurological problems, okay? Otherwise, the patient may land up into some severe neurological problems and you will think that, no, we are happy that it is praised. You have to take documentation of each and everything. You have to counsel the patient and relatives from time to time. Okay, so friends, crisis is integral to human life, and those who timely and appropriately contract it will survive and succeed. That is what Geeta said. Okay, so I can ask you one message from each panelist and what take-home message we want to give. We start from Dr. Tapan.
Yes, ma'am.
Yeah, what message you want to give to our attendees or to our colleagues that for HDP, how you should, act in your hospital? Right from OPD, first visit, okay?
Frankly speaking, madam, if it is mild hypertensive, then under strict monitoring we will continue. But suppose patient is
development of, I want you to give a message right from prevention, okay? Prevention.
Suppose a patient has a previous history of hypertensive, or suppose a patient is more than 35 years of age, then I will like to start aspirin from the first trimester.
Right. But you know that, priming itself is a priming and high multiparity, both extremes. And
Yes,
18 years, that is teenage, and more than 35. So both the extremes are high risk. Okay. So high risk patients need to be scored by HDP. Every patient who presents to you in OPD should be scored by HDP Justosis score. We should take this into consideration. And if it is more than 3, you start them on low dose aspirin and high dose calcium. Okay. Dr. Bhavish, one message from you. Dr. Bhavish.
Yes, madam. We evaluate the high-risk patient by the first trimester and second trimester uterine PI, and we go for the preventive measure by the aspirin 150 milligram. It may be prevent up to the 60 to 70% is for developing the PIH. And during the last trimester, we regularly monitor the blood pressure and urine albumin, and warn the patient about the warning sign of the PIH. And growth restriction sonography at the 32 weeks.
Right.
And we keep ready for the
next message we will have from next panelist. Okay. So yes. Anybody next? Hello.
Yes, ma'am.
Yeah.
Yes, ma'am. We should not consider easily preeclampsia. It is very dangerous condition, and as per my opinion, we should, if fetus is 32 weeks, we should, as possible, terminate pregnancy as fast. Otherwise, there is no any medication which can prevent eclampsia.
Yeah, but then we have said no that we can take the pregnancy up to salvage.
I have one case, ma'am.
We can explain the patients. We should explain people and patients in general in society, girls' health by adequate calcium, not having junk food, and after pregnancy too, many patients don't consider calcium as a requirement. They think that iron tablet will suffice. So calcium is very important at when the first wave of trophoblastic invasion start at 12-14 weeks. So it's important to take calcium too for patients.
Correct.
Along with the this homocysteine lowering vitamins, the 3 vitamins like folinic acid and pyridoxine with B12.
Okay, so that's a very good message for prophylaxis. But as Dr. Chaudhary is saying that, you have to terminate the pregnancy at 32 weeks. No, we have already discussed. If at all
the patient is already in fulminant preeclampsia, not for all.
That is what we say. When do you need to terminate the pregnancy? If at all you have maternal complications very severe, or you have some fetal problems. Right. That you are right. Okay.
Yes, ma'am.
Okay. Yes, Dr. Jhalak, Dr. Nesargi, Dr. Vishang.
Ma'am, I have one question.
Yeah. Let us have the message first, then we discuss it.
Okay.
Yeah.
So,
Dr.
ma'am,
Vikram?
gestational hypertension, the newly diagnosed patient should be managed with expectant management at OPD level only. And we should keep a watch at we are treating two, the mother and fetus both. So we should keep a watch if the hypertension is progressing towards the eclampsia or preeclampsia. Then the emergency steps should be taken as soon as possible.
Okay. Anybody else? Yes, Dr. Priyanshu?
He can proper examination, proper investigation, and take
You
care
take the
about
blood pressure yourself personally. That is the most important message I would say. Okay. Take
Yes.
the blood pressure yourself personally, because there can be n number of variations. You are not sure that, because blood pressure is the only indicator that you can know that she is having hypertension. Okay. So at every visit, you should take the blood pressure personally. Okay.
Yes, ma'am.
Okay. Anything else? Anybody else? Dr. Naisargi, you want to say something? Single message from your side. Okay. I think, yeah.
So, thank you, ma'am.
Yes, please go ahead. Okay. Dr. Chaudhary, you can ask your question.
Yes, ma'am. There is one word, atypical eclampsia. I have seen at least 10 patients. Those have all the vitals normal, blood pressure normal, urine albumin nil, and
Yes.
intrapartum or postpartum, they have episode of convulsion.
Yes.
So we should consider its condition as a eclampsia.
Yes. In fact, it has been, the newer guidelines which are coming from Justices, they are saying that you may not even have proteinuria, even simple mild hypertension, what you can call it as, that also can lead to convulsions also. So atypical patients, atypical eclampsia also do exist. So, but you have to be very vigilant on your monitoring, and you have to notice even the slightest change in the blood pressure. That is what I'm trying to tell you. Okay. So prediction, you have HDP gestosis score. Prevention, you have low dose aspirin and high dose calcium. And preparedness, the very first reading of 140/90, you should, raise your antenna, your high index of suspicion. You investigate her thoroughly, and you categorize her whether severe or non-severe. And if at all she has hypertension, you have to start the effective and safe antihypertensive at the earliest. You have to monitor these patients stringently, and you know that she's a high risk patient. Anytime she can land up into induction and delivery. So you have to prepare the fetus very well, as you all have discussed. So that is how you have to manage this patient. And you having hypertension, you cannot prevent, but definitely you can control and stabilize this patient. So if your patient convulses under your treatment, then that reflects on you very badly. Okay. So you must use anti-convulsant and anti-convulsants very effectively. Okay. Anything else you want to add?
Ma'am, we all should download Justice's score, and we have to follow from first ANC onwards, so we can not miss any gestational hypertension or preeclampsia cases.
Yes, perfect. That is what I'm trying to tell you, that you must try and use HTP gestosis score, so that you can definitely predict, and then you can. So friends, thank you so much. That was a wonderful discussion, and all of you have contributed very well. I'm sure even the attendees have helped. Yes, Dr. Archana. So I just take this opportunity to humbly request all of you to please nominate me from your society, and please post my flyer on your society group or share with your members. Please do vote for me, and make me your representative as Foxy Vice President from West Zone. So with this, I thank all of you, and I hope we have done justice to this panel discussion. If at all there are any comments and any queries, I'm here to answer. Thank you so much. Do we have Dr. Archana?
Yes, ma'am, I'm very much here. I was listening to the panel.
Yes.
And I think you don't have to say, because your hard work speaks for itself, I think. We have seen you working very closely since last so many years, very dedicated person. So I think and Monica also here. I mean, I said in the starting as well, when I imagine PSC, it is Monica only. So God bless you and best wishes from Gujarat. And Sneha ma'am, I think you deserve to be in the bestest form every time. So I think Gujarat has witnessed you so much. I think myself, Kazi, Vishang, everybody else, Sanjay sir, Narbat is there, Jalak is there, Navish bhai is there.
Dr.
So
Vishang,
everybody, Doctor, I think we all have all wishes towards you only. So hoping the best for your Foxy tenure ahead.
Thank you. Please consider me as your candidate because, I belong very much to...
Sure, sure.
Yes.
Thank you very much, ma'am. Thank you very much. It was an excellent panel. And on behalf of you, I am going to appeal all the delegates and faculty. Please vote for Sneha ma'am. She is the best deserving candidate for the Foxy West Zone VP election.
Okay, all the
And thank you very much, all the
I can
panel.
see Soni sir. I can see Soni sir. Sir, can we have your blessing, sir?
Sure, 100%. Our whole society will be with you.
Sir, thank you so much. Thank you so much.
Sure,
Thank you so much, everybody.
Yeah.
And
Thank you, Sarfraz sir. Thank you, Archana ma'am, for allowing me to coordinate.
Also.
Thank you, sir. Please nominate, sir. Election ના થવા જો એટલું જો.
ના નહીં થાય ઇલેક્શન તમારા નામે
તો તો અનઅપોઝડ આવી જવાની મને એવું જ લાગે.
ના ઇલેક્શન થશે મેડમ છે.
Archana, your specs are very good.
Oh, thank you, sir. Sorry, sir. Good evening. Good to hear from you. Thank you, sir. Thank you so much.
thank you so much. Thank you so much for all your blessings and all your wishes.
We really enjoy.
Thank you, Shubham, for the flawless technical support.
I would love to have all of you with me. As you all know that, Archana was my committee member when I was a press committee chairperson. Archana, Kirtan, and there were so many, Kamini Patel, all of these were my committee members, and I have taken them along and they have worked so hard for the committee. Likewise, as a vice president from West Zone, I'm going to have all of you on board. So we will have lots of activities together. Okay.
Sure.
Thank you so much.
Thank you, ma'am.
Bye. Good night.
Bye-bye.
Good night, everyone. Thank you, ma'am.
Good night. Good night, ma'am.
Good night, ma'am.
Good night. Good night. Bye-bye.
Chalo. Manjuben Puru.